Okay, welcome to the 39th lecture of Dr. Heidi Step 1. Can you guys hear my voice? Can you guys hear my voice? Is the voice clear? Okay. Thank you so much for waiting for 10 to 15 minutes for everyone to join. Um, Eventually, what we are going to do is we are going to start our lecture at 9 a.m. And the students who are a bit late to join the lectures, we will just provide them with the videos and they can get ahead, and at the same time we will be saving some time, so that's exactly what we are going to do from tomorrow. From tomorrow onwards, we are going to start exactly at 9 a.m sharp. Okay, having said that, how many questions did you guys do last yesterday? How many questions are we doing from you world? Can we get some solid answers, please? 40, 20, 30. Okay, that's very good. Okay, did every one of you get access to the Google Drive lectures? Our team was supposed to send you all the lectures from 31 to 38. Okay, that's very good to know. So, to all the students who had issues or who had problems accessing the lectures, now you guys can access lecture 35, 36, 37, 38. We had a small mistake with lecture 37. It said lecture 36 instead of lecture 37. That's what I wanted to aware you guys with. Okay, but one of them is 37. That is the date for which the lecture 37 was 2 days ago. So that's that. Okay, so we are going to change the name for that one. So please do not get confused. Okay. Okay, very well. Another thing is, what about the neurology assessment exams? Uh, what about the neurology assessment exam? How did you guys do in the neurology assessment exam? How many of you guys have finished the exam, and how did you guys do? Good, bad? How was it? We don't need to know your actual number right now. Just want to know how it went because we posted the answers yesterday. Okay, good. So before, another thing is, what we want to discuss is the chapters which we did yesterday. Okay, so our lectures are divided into four segments. The first one is revision and recapitulation, which we will do for for the first half an hour to 45 minutes. But it took us a long time to start our lecture for today. It took us like 10, 15 minutes. So we are going to keep this very short so that we don't fall behind or while we cover the renal system. Okay. So let's do a very quick revision and recapitulation of yesterday's lecture. Are you guys ready? Everyone, are you guys ready to start the revision and recapitulation? Okay, let's begin. Okay, so our questions are going to be directed to students directly instead of everyone answering because we just want to make sure that everyone has understood. So we will unfortunately put you on the spot and ask you the questions. All you guys need to do is use the chat box to provide your answers. Okay, please refrain from looking at the book and providing the answers because at the same time you can also test yourself whether you have understood the topics from yesterday or not. Okay, so our first question. Okay, so our first question goes to Dr. Fagan. Would you be kind enough to tell us what is the shape of the calcium phosphate stones?
Calcium phosphate stones depend upon, oh, wait a minute, sorry. Calcium stones depend upon what kind? The calcium phosphate stones are prism shaped.
Very good. Thank you so much. Okay, thank you so much. So it's wedge shaped or prism shaped. Okay. For what we are going to do is for right now, we are going to use the chat box to provide the answers. Then eventually, when we discuss, then we will access the then we will refrain from using the chat box. Okay, so right now, since I need to go through this fast, let's use the chat box to provide the answers. Thank you, Dr. Fagan, for your answer. The next question goes to Dr. Hossam. Would you be kind enough to write down what is the shape of the uric acid stones? What are the shapes of uric acid stones? Fast answers, please, Dr. Hossam. The questions are directed to the students who are asked only, please, because we just want to make sure that everyone has understood. Okay, you forgot. Very good. Thank you so much. Uh, uric acid stone. Then the next question goes to Dr. Evelyn. Would you be kind enough to tell us the shape of the uric acid stone, please? Fast answers, yes or no? You remember? Very good. Thank you so much. Can we have the next question directed to Dr. Ahmed? Dr. Ahmed, would you be kind enough to tell us the shape of cystine stones? Cystine stones, hexagonal shape. Very good. Thank you so much. Can we have the next question directed to Dr. Uday? Would you be kind enough to tell us what do you see in the light microscopy of minimal change disease? Very good. Can we have the next question directed to Dr. Gianni? Would you be kind enough to write down what do you expect to find in the light microscopy of diabetic nephropathy? Dr. Gianni forgot. Sorry, no problem. Okay, now everyone, what do we expect to find in the light microscopy of diabetic nephropathy? Okay, Kimmel-Stahl-Wilson nodules. Kimmel-Stahl-Wilson nodules. Very good. What is Kimmel-Stahl-Wilson nodules? It's a hyperfiltration sclerosis and hyalinosis due to the formation of due to the hyperfiltration damage that occurs. Okay, very well. Okay, next one. Next one is what do we expect to find in the immunofluorescence of acute post-streptococcal glomerulonephritis? The question is for everyone. Acute post-streptococcal glomerulonephritis. Lumpy bumpy. Very good. Can we have the next question directed to, okay, the next question, can we have it directed to Dr. Hassan? Would you be kind enough to write down what we expect to find if in rapidly progressive glomerulonephritis, if we do an immunofluorescence test, it's negative. After that, we do CANCA or CANCA, and that's positive. What do we what's your professional diagnosis? Wegener's. Very good. Thank you so much. Can we have the next question directed to Dr. Iman? Would you be kind enough to tell us what do we expect to find in the electron microscopy of Alport syndrome? Dr. Iman, would you be kind enough to write down what you expect to find in the electron microscopy of Alport syndrome? Okay. Can we have this question directed to Dr. Abioba, Dr. A. Abiudin? Okay, can we have this question directed to Dr. Maheshwari? What do you expect to find in the electron microscopy of alportism? Very good. Okay, Dr. Abiudin, it's basket weave. Very good. Okay, very well. Next one is what is the primary damage in nephritic syndrome for everyone? What is the primary damage in nephritic syndrome? Nephritic inflammation of glomerular. It's a glomerular basement membrane damage. Very good. What is the primary damage of nephrotic syndrome? Podocytes. Very good. Okay. If I tell you there's focal involvement, what does that mean? Focal involvement less than 50. Diffuse involvement. Okay. Proliferative. What do you mean by proliferative? Okay. What do you mean by membranous? Okay. Let's talk a little bit about casts in the urine, urinary casts. Okay. Do you guys remember the mnemonic that we used to remember RBC casts and where we can find them? Go hyper or get hyper. That stands for that stands for glomerulonephritis and hypertensive emergency. Very good. How about WBC casts? WBC casts. Tattoo. Okay. Tat 4, tubular interstitial inflammation. A4, acute pyelonephritis, and another A4. Another T4, transplant rejection. Very good. Where do we find granular casts? Very well. Where do we find fatty casts? Okay. Where do we find waxy casts? Waxy casts. Okay. Hyaline casts. Hyaline cast. Non-specific. It's a normal finding. Okay, very good. Thank you so much for answering all these questions correctly. And that's that. Okay. Having said that, the only thing that you guys need to revise and review off again and on and off again are the nephrotic syndromes and the nephrotic syndromes. That is very, very high yield. Okay. So that's what you guys have to do. Make sure you guys do it at least once a week so that you guys don't forget. Or even if you guys do not feel like looking at the book, if you guys try to listen to our lectures or look at the lecture once again, hopefully then you guys could answer these questions again. Okay, so having said that, are we ready to begin the lecture for today? It's 9:30 as of right now. We don't want to waste any more time. Okay, very good. Having said that, let's begin. Okay. So the lecture that we're going to do is we're going to finish renal pathology and start with renal pharmacology. And we're going to move a little bit fast today because what we want to see is we want to make sure that we're ahead on our schedule. And the page number that we are going to begin with today was most probably the one with hydronephrosis. Okay, that's what we're going to do. So what is first and foremost, What is hydronephrosis? Let's wait for this to start. What is hydronephrosis? Hydronephrosis is basically the condition where you have distension and dilatation of the renal pelvis, right? And that usually occurs if there is a distal obstruction. Okay, that usually occurs if there is a distal obstruction. That is hydronephrosis. Okay, what are the causes of obstruction? What are the causes of obstruction? First of all, let's talk about the causes of the obstructions. Okay, so let's say that let's say that this is your kidney. Okay, over here, right? If you have any obstruction over here, the water will accumulate. Okay, the urine will accumulate, and this will make the kidney bigger, boggy, right? And this is known as hydronephrosis. Okay, so what's happening with hydronephrosis is, okay, 1 second. Okay, so what happens with hydronephrosis is, in hydronephrosis, you have obstructions, which are the main causes. So what are the things that can obstruct the flow of urine? First of all, the number one cause of obstruction could be stone, right? If there is a kidney stone, then that could obstruct the flow. Another one is, okay, another one is, let's say that it goes all the way to the bladder, right? And then it comes down, and then over here you have the prostate. Okay, and then over here you have the prostate. If there's inflammation, I mean, if there is BPH, then this can cause obstruction over here, and then all the way this will put pressure, and the pressure will go up. So the next cause is BPH. Okay, another things are another thing is if there is urethral rupture or rupture of the urethra. Okay, so over here we have a urethral rupture. If we have a urethral rupture over here, then then there could also be a backflow of the urine, and then the urine will build up, and that can also cause hydronephrosis. So the next one is urethral rupture. Okay, urethral rupture, and then in a female patient, over here, what we have is are the cervix. Okay, if there is a cervical carcinoma, that cervical carcinoma can spread all the way to over here, obstructing the flow of urine. So that is another one. That is cervical carcinoma. Okay, cervical carcinoma. Another things that can usually happen are, in young children, we can have posterior urethral valve. So we can have some congenital anomalies. Along with this, we can also have another condition known as retroperitoneal fibrosis, and vesico urethral vesico vesico urethral reflux. Okay, so we will talk about all of these things. So basically, these are mostly all the causes that can cause the flow of urine outside, that can obstruct the flow of urine. As a result, the urine will accumulate over here, and they can cause hydronephrosis. Okay, so that's that. Okay, so this is basically hydronephrosis. If you can see the ultrasound image over here, the ultrasound image. In the ultrasound image, you can see that there is accumulation of urine inside the kidney, and the kidney has gotten the, there is swelling of the kidney, and there's distension and dilatation of the renal pelvis. Okay, what are the sign symptoms of hydronephrosis? Sign symptoms of hydronephrosis. What will the patient complain about? Okay, patient complain about. So symptoms. Symptom wise, what will the patient complain about? The patient will complain, number
Master,
one.
some of my friends are saying they are waiting. Could you let them in, please?
Okay, 1 second. Oh, so to everyone who has just joined the lecture, welcome. We just started talking about hydronephrosis. We just started up talking about hydronephrosis. We talked about the obstructions that can cause hydronephrosis: stones, BPH, urethral rupture, cervical cancer, congenital anomalies, retroperitoneal fibrosis, and vesico-urethral reflux. Now we're talking about the symptoms that a patient will complain about. Okay, excuse my handwriting; it's completely horrible. Just give me 1 second. Let me see if I can make it a bit better. Okay, sign symptoms. What will the patients complain about? Okay, number one, the patient will complain about heaviness. Okay, heaviness in the flanks, heaviness in flanks. Okay, even you will have questions in your world. Well, they will tell you that the patients are complaining about a heaviness in their flanks. Okay, and difficulty sleeping, difficulty moving or sleeping. Obviously, because the kidney has been distended, and this will put pressure. And number three is flank pain. Okay, flank pain. Okay. Well, what are the signs you will see as a physician? Signs that you will see as a physician are renal angle tenderness. Okay, renal angle tenderness and palatable, palatable kidneys. The kidneys will be palatable. What do you mean by palatable? Does anyone know what palatable means? What do you mean by palatable? Have you guys ever done tests?
Palpable?
Have you guys ever done tests in your wards where where you try to see if you can, right? Very good. So palatable kidneys. Okay, very good. So that's that. Okay. So having said that, the dilatation will occur proximal to the site of the pathology, meaning that the pathology is the distal side. Serum creatinine becomes elevated if obstruction is bilateral. Okay, this is high yield. If obstruction is bilateral, the serum creatinine will be elevated. Or if the patient has an obstructed solitary kidney, leads to compression and possible atrophy of the renal cortex and the medulla. Okay. So first of all, bilateral hydronephrosis can cause creatinine elevation. That is important for your USMLE step one, because unilateral hydronephrosis will not cause elevation of serum creatinine. So do not expect the serum creatinine to be high in your URL questions. Next one is, this is a possible histological finding. Okay, they will tell you that in the histology they found that that's how they will describe the question and direct you to hydronephrosis, is that they will tell you that they have found that in the histology that there has been atrophy of the renal cortex and medulla. Why is there atrophy? There is atrophy because let's say that this is your kidney, right? And there is so much water over here that this is pushing the renal cortex and medulla towards the outer cortex. It's pushing it. So this excess pushing of the cortex and medulla towards the outer capsule will cause atrophy of the cortex and the medulla. And cortex atrophy and medulla and the swelling of the kidney is very, very diagnostic of hydronephrosis. Okay, so that's that. Uh, as a whole, hydronephrosis is not extremely high yield, but the concept of hydronephrosis is very important to understand. So that's that. Having said that, the next one that we want to move on to, the next one that we want to move on to is urinary incontinence. And we have discussed urinary incontinence before when we did our URL notes. Okay, so urinary incontinence. What is urinary incontinence? Urinary incontinence means failure to. Can anyone describe urinary incontinence, please? Failure to what? Failure to? Can anyone describe incontinence? Okay, but okay. So, Dr. Noth, failure to control voluntary micturition. Very good. That is a very good definition. That's exactly what I was expecting. That is, you fail to control your micturition process, that is, hold or release your micturition, and your failure to do so is known as urinary incontinence. How many types of urinary incontinence do we have? We have three types. Okay, what are the types of urinary incontinence? We're just going to go very fast because we have discussed this before. We have stress, we have urge, and we have overflow incontinence. Okay, so let's talk about them one by one. Okay, we talk about them one by one. So in stress incontinence, okay, let's talk about stress incontinence. So what happens in stress incontinence is that first of all, we will talk about the patient presentation, okay, clinical features, what the patient will complain about. In your URL questions, you will have questions where they will tell you that the patient has leakage of urine, leak with sneezing, sneezing, coughing, lifting. Basically, anything that will increase the intra-abdominal pressure will cause stress incontinence. So sneezing, coughing, and lifting. Okay. So and another thing is another thing is this is what the patient will complain about. Now you as a physician, as a sign, there is a sign that you can do. This sign is known as Valsalva. Valsalva. I'm pretty sure we all know what Valsalva is. Valsalva maneuver, where we try to hold our breath, expand our diaphragm, push out on the abdomen by the rectus abdominis, push out on the abdomen by the rectus abdominis, and this increases our intra-abdominal pressure. And if you make the patient do the Valsalva, then you will see that there is leakage of urine. That's the test which you can do as a physician. But for your URL, your URL, please do not forget leak with sneeze, cough, and lifting. This will help you realize that that the incontinence is stress incontinence. The way that I would like my students to remember this is is working out and exercising and working out. Is this a stressful condition or not a stressful condition? Fast answers, please. Stressful condition or not? Working out. Is this a stressful condition or a very calm and composed type of situation going on where you are lying back watching Netflix, chilling? No, it's a very stressful condition. Okay, so your body is in extreme amount of stress. So during workout, okay, during workout, especially, have you guys ever tried working on your abdomen, your abs, your abdominal muscles, your core workouts? Do you guys have any idea how stressful that is? Okay, we can have guys over there in the gym curling for biceps and working on their chest and back, but they never want to hit their abs because working on your abdominal muscles are extremely stressful. So working out is stressful. Okay, stressful. So anything that will increase the abdominal pressure, such as lifting, sneezing, coughing, will cause stress incontinence. Do not forget that. Okay. Next one. Next one is the, so we talked about the signs. Okay. Now let's talk about the reason. I mean the mechanism. Why does stress incontinence happen? What are the cause of stress incontinence? The number one cause of stress incontinence is that the mechanism is urethral hypermobility. Urethral hypermobility. Okay, so there's urethral hypermobility. So if we have, let's say, the bladder, this is the urethra, right? So if there is urethral hypermobility, if there is excessive mobility of the urethra, what happens is when there is increased intra-abdominal pressure, the urethra, due to the hypermobility reasons, it kind of relaxes. When it relaxes, the urine can easily flow out, and the patient will have decreased control over their incontinence. That is one cause. Another cause is internal sphincter internal sphincter deficiency, meaning internal spinster deficiency. So basically, we have two types of spinster. We have the internal one, which is involuntary, and then the external one, which is voluntary. The external is still in our control. The internal one is not in our control. The internal spinster are lax, and so due to the laxity of the internal spinster, the urine can flow out during sneezing, coughing, and lifting, and that is exactly what happens. Okay, how do we treat a stress incontinence? The treating of a stress incontinence is very easy. We have to do pelvic floor exercises, pelvic floor muscle, pelvic floor muscle exercise, exercise. Okay, and you will ask you 100% which muscle are you going to target for the pelvic floor muscle. Okay, and the name of the muscle is levator. Do we have a question? Do we have a question? Okay, no question. The name of the muscle that we are going to try to target is, okay, the name of the muscle that we are going to target is levator ani. Levator ani. Okay, that is exactly what we're going to do. This pelvic floor muscle exercises, they're also called Kegel exercises. Kegel exercise. Kegel. Okay. Kegel exercises. So that's that. Okay. Are we clear with stress incontinence? Are we clear with stress incontinence? Easy to understand. We have discussed this before, so we're just gonna move on very quick. Okay, the next one that we want to talk about is urge incontinence. Urge incontinence, meaning that you have extreme urge to void. Okay, so next incontinence that we wanted to discuss is urge incontinence. Urge incontinence is you have an extreme urge to void. So basically, what happens is the mechanism. First of all, let's talk about the clinical features, that is the signs, symptoms. Symptoms, patient will tell you that patient has an urge to void and leakage of urine, urinary leakage while rushing to the bathroom. Okay, while rushing to toilet or bathroom, meaning that the patient had an urge to go to the toilet. The patient took the initiative to go, and during performing the action of going to the toilet, the patient could not hold his or her urine, and it leaked out because of the extreme urge to void. This is known as urge incontinence. The mechanism is very easy. The mechanism is that, let's say this is the bladder. Okay, okay. Do you have the detrusor muscle over here? Okay, there is extreme detrusor overactivity. If there is the detrusor overactivity, this will cause contractions of the bladder, and this contractions of the bladder will push down the urine, and this is exactly what happens over here. So the mechanism is detrusor overactivity. Okay, detrusor overactivity. Okay, what are the causes of, can you guys give me an example of urge incontinence and which type of pathology we can get urge incontinence? Very good. UTI. Okay, in UTI, if there is inflammation of the detrusor muscles, for example in cystitis, okay, then this can cause irritation and detrusor overactivity, and that's that. Okay, so if we have to treat urge incontinence, what do we do? First of all, first of all, we can give antibiotics to treat UTI. That's what we can do. Okay. Next one is give we can give another drug. Okay, that is anti-muscarinic. Okay, anti-muscarinic, and this is very high yield. You guys will be asked about the treatment of. You guys will be asked about the treatment. Okay, of urge incontinence over and over again. So please try to remember that we give anti-muscarinic, especially the drug is oxybutynin. Oxybutinin. Okay. Okay. Um, okay. Is atropine an antimuscarinic? Atropine, yes or no? Okay. Do you guys remember that in excessive atropine use, we have dry mouth, constipation, uh, urinary retention, urinary retention? What does that mean? What does that mean? Basically, let me break it down for you. Okay, just give me some time. Just let me help you master the concept. Okay, so atropine, if it's an anti-muscarinic, okay, so if it's causing dry mouth, constipation, and urinary retention, okay, so basically, is it mimicking a sympathetic reflex or a parasympathetic reflex? Sympathetic or parasympathetic? It's basically mimicking. Okay, it's not doing a sympathetic; it's mimicking a sympathetic reflex. Okay, sympathetic reflex. So in that case, if I have to ask you that your that if you have to go to the toilet and perform your micturition tasks, okay, if you have to let go of your urine, do you have to be in a sympathetic state of mind or in a parasympathetic state of mind? You have to be in a parasympathetic state of mind. And this is actually a psychiatric issue for a lot of people who cannot use toilets other than their own toilets because they cannot be in that parasympathetic state of mind because to let go of the urine. So, so the thing is, if you can take advantage of this situation, okay, if you can take advantage of this situation and you give a drug which will cause which will cause sympathetic activity, especially of nowhere else, directed specifically towards the bladder muscle, specifically towards the bladder muscle. Then if you can make the bladder muscles undergo sympathetic activity, then can you not control the bladder, prevent the bladder from leaking it with urine? Yes or no? Yes. So that's exactly what happens over here. That is this anti-muscarinic, especially oxybutinin, that specifically targets the muscarinic receptors, that are the parasympathetic receptors over here. So they block the parasympathetic, and blocking of the parasympathetic receptors will eventually cause activity of, I mean, I'm talking about the cholinergic receptor. Okay, so blocking the cholinergic receptor will will result in in your mimicking of the sympathetic activity of the bladder muscle, and this will cause decreased release of the urine. Another drug that we can use is mirabegron. Okay, okay. Does anyone know what mirabegron is? Anyone? What is mirabegron? Very good. Okay. What is mirabegron? Does everyone agree with Dr. Adhanom, the Dr. Uday, Dr. Ibrahim? Okay. So what would happen if we use a beta agonist over here? Will it cause sympathetic activity or parasympathetic activity? Mirabegron. Sympathetic activity. Once again, we will take advantage of the sympathetic activity of the bladder, and this will cause decreased activity, and this will cause decreased activity of the detrusor muscle and prevent the urine to leak out. So that is urge incontinence. Okay. So for stress incontinence, remember that there's leakage of urine during sneezing, coughing, and lifting. Urge incontinence, there's leakage of urine when rushing to the toilet. Okay, next one. Next one that we want to talk about is overflow incontinence. So what is overflow incontinence? Overflow incontinence is basically, okay, what is overflow incontinence? We talked about overflow incontinence yesterday. Who remembers talking about the patient with the BPH? Do you guys remember we talked about that? Yes or no? That we had Dr. Hossam ask us what type of incontinence this was. Okay, so that's overflow incontinence. So So what is overflow incontinence? Okay, overflow incontinence is, let's say that this is the bladder. Okay, let's say that over here you have the obstruction. Okay, now if there is a detrusor muscle which contracts in order to void the urine, not a lot of urine can go through over here. Okay, they might push through the obstruction and there could be dribbling of urine. Okay, there could be dribbling of the urine, but there will always be some amount of urine that is left over here. Okay, so patient will complain. Clinical feature. Clinical feature is that the patient will complain of feeling incomplete, feeling that there has been an incomplete emptying of bladder. Patient will complain that there has been a feeling of incomplete emptying of bladder. Okay, and as a result, that's what the patient will complain about, and that's how your U-World questions will present to yourself. And signs. As a physician, you will see that the patient has increased PVR volume. What is PVR? PVR is post-voidal residual volume. Post-voidal residual volume should not be more than 0 to 150 milliliter. Over here could be close to around 500 or more. Okay, either this can be seen on ultrasonogram, or if you do a catheter, if you put in a catheter, you will see that the extra urine that comes out is actually more than 500. So there has not been complete emptying of the bladder. Okay, what are the causes of overflow incontinence? First of all, causes are obstructions. Number one causes for males, BPH. For females, this could be cancer, cervical carcinoma. Another one for both males and females is detrusor underactivity, not overactivity, detrusor underactivity. Okay, so detrusor muscle underactivity or obstruction, that is BPH, and BPH and cervical carcinoma. Also, if we have any other condition, for example, let's say there is another neurological condition such as multiple sclerosis, in which we have demyelination of the nerves of the central nervous system, and this will cause decreased transmission of impulses to the detrusor muscle, and as a result, there could be detrusor muscle inactivity. Okay, any other neurological condition can also do the same thing. So that's that. How do we treat a patient with overflow incontinence? Treatment is very easy. First of all, since there's excess leftover, get rid of the leftover. How do you get rid of the leftover? Perform a catheter. You insert a catheter. So catheterization. Next one is, what do we do? We use a very different drug for this one. For overflow incontinence, what we do is we use an alpha blocker for obstructions. Alpha blocker. Okay. Can you guys name an alpha blocker for BPH? First of all, why do we use an alpha blocker? Basic knowledge. Why do we use an alpha blocker? Okay, good. Alpha blocker to relax. That is good. Okay, prevent vasoconstriction. Okay. What are the names of some alpha blockers that could be used? Prazosin, terazosin, tamsulosin. Okay, so alpha blocker for BPH. Okay. Can I ask some questions? Doctor question. Yes, Dr. Hassam, what is your question? Fast, please. In normal pressure hydrocephalus, what happens? Normal pressure hydrocephalus, what happens, which type of continence? Okay, in normal pressure hydrocephalus, does normal pressure hydrocephalus have anything to do with urethral hypermobility? Yes or no? Okay. Does normal pressure hydrocephalus have anything to do with detrusor overactivity? Can normal pressure hydrocephalus decrease transmission of impulses to the detrusor muscle and cause detrusor underactivity? Good. Okay. So, what type of incontinence is normal pressure hydrocephalus? Overflow. Okay. Due to detrusor underactivity. Very good question asked by Dr. Hazam. Okay. Did any condition which can cause decreased transmission of impulses to the detrusor muscle can cause detrusor underactivity that can cause overflow incontinence. Are we all clear? Okay. Can we ask some questions directed to specific doctors to make sure that everyone has understood? Because when we ask the questions to everyone, everyone kind of answers the same thing, and we can. It's hard for us to differentiate if everyone has understood or not. Okay. Can we ask the question to Dr. Aldera? Would you be kind enough to answer this? If a patient comes to you with increased amount of urinary leakage during sneezing, coughing, and lifting, what type of incontinence is this for Dr. Aldera? What type of incontinence is this? Thank you so much. It's stress incontinence. Can we have the next question directed to Dr. Samra Hussain? Would you be kind enough to write down what type of incontinence is happening if a patient has BPH or cervical carcinoma? Dr. Samra Hussain. Overflow. Very good. Next one is, can we ask the next question to Dr. Ruba? Would you be kind enough to tell us, would you be kind enough to tell us what type of incontinence do we expect to find in a patient with UTI? UTI. Can we ask this question to Dr. Evelyn? Would you be kind enough to tell us what type of incontinence we find in UTI? It's a very easy question. Thank you so much. It's urgent incontinence. Okay, so nowadays that's exactly what we're going to do. We're going to ask the question directed to specific students to make sure everyone has understood, and we will ask everyone one by one, and all the students will have to answer at least one question. Okay, so thank you so much, guys, for answering these. Has everyone understood how the incontinence question will present in your world? Yes or no? This question goes for everyone. Very good. Okay. Next one. Next one is very, very easy. Okay. Next one, I'm pretty sure the next thing that we have to discuss is cystitis. Extremely easy thing to study, because what is cystitis? Basically, cystitis is basically inflammation of the urinary bladder. Okay. How will you have questions from cystitis? The question presentation is this one. They will have question. They will tell you that a young female or a male, specifically this question is directed for females, that they will come with suprapubic pain, dysuria, urinary frequency, urgency. Okay, pain, dysuria, frequency, urgency. Okay, specifically all the signs of lower urinary tract symptoms. Lower urinary tract symptoms. What are the signs of lower urinary tract symptoms? That is frequency, urgency, dysuria, suprapubic pain. Along with this, the patients can have high fever, chills. Okay, how many of us over here, male, female alike, have undergone UTI? It's a very common disease. Everyone. Do we have anyone over here who has never had UTI in their life? I had UTI. Everyone had UTI. Okay. Doctor. Okay. So we have. Okay. So it's extremely rare that, let's say if we have 30 students over here. Okay. Close to around 25 to 26 students should know or should have had UTI at least once in their life, male or female. For male, the frequency is very less. For females, the frequency is unfortunately a bit high. So that's that. So that's exactly what it is. So I'm pretty sure since you guys have went through this, you guys know exactly what the signs symptoms of UTI is. So we're not going to go into any more details. The risk factors are usually more for female sex because they for the fact that the urethral course of the females are a bit shorter. Okay, so shorter urethral course, and that is a question in U World. Okay, why are females more at risk of UTI or cystitis? That is because of the short urethra. Next one is sexual intercourse. Okay, next one is indwelling catheter. This is the most common cause of UTI in hospitals setting. Okay, if you are a physician and you have a patient who needs catheter. Okay, your job is to make sure that as soon as the patient is capable to void urine by themselves. Okay, depending that there is no underlying pathology, it should be your duty to remove the catheter as soon as possible. A catheter should not stay for more than 3 to 4 days. Okay, so that's that, or maximum 1 week, but even a week of having a catheter is extremely dangerous in the fact that it can put the patient at a high risk for cystitis. Next one is diabetes mellitus. Okay, and impaired bladder emptying. If you have diabetes mellitus, your blood sugar level is always very high, and increased amount of blood sugar level is very potent for bacterial or any other microorganism growth. Another one is impaired bladder emptying. If you have impaired bladder emptying, then the longer the urine stays, the urine contains a lot of metabolic toxins, microorganisms itself. Okay, if it stays for a long period of time, this can cause infection and inflammation. These are all the causes and risk factors. Out of all of them, two are important for your UL: indwelling catheter, most common cause in hospital setting, and female sex for short urethra, because that puts them at a higher risk for having UTI. What are the common organisms for causing UTI? Number one is Escherichia coli. That is the most common. Next one is Staphylococcus saprophyticus, seen in sexually active young women. And this is asked very commonly in UWorld. And most of these questions are directed from the microorganisms. I mean, from the microbiology. They will ask you to describe these microorganisms. So that's that. Then we have Klebsiella. Last one is Proteus. Okay, last one is Proteus. So E. coli, Klebsiella proteus, and Staphylococcus saprophyticus. Labs. What do we see in labs? We see that we see leukocyte esterase test. If it's positive, that's an indicator. If we want to see that the organism is gram negative, then we will do a nitrite test. If nitrites are positive, then we can understand that the organism is gram negative. Another thing is sterile pyuria. This is another question in your UL. What is sterile pyuria? Sterile pyuria is that the patient has UTI, but in blood culture, or in urine culture, there is no growth seen. Okay, this suggests that this suggests that the urethritis could be caused by Neisseria or chlamydia. Okay, and what is the treatment? The treatment for acute cystitis is very well known. That is trimethoprim, sulfamethoxazole combination, or nitrofurantoin. Nitrofurantoin. So that's exactly what it is. Okay, we read through this acute cystitis because I know this should be very easy to understand and very common. Are we all clear about acute cystitis, about how the questions will present and what we have to see and look out for? Okay, very well. If you guys have any question, please let me know. Okay, now next one. Next one that we want to discuss is acute pyelonephritis and again chronic pyelonephritis. Okay, we can also do the same thing, that is read through acute chronic pyelonephritis and chronic pyelonephritis, but I just want to discuss one single thing over here. First of all, what is pyelonephritis? Pyelonephritis is basically infiltration of the infection or inflammation of the renal interstitium, of the renal interstitium. This will affect the renal cortex, but this will not affect the glomeruli and the blood vessels. Pretty sure that's exactly what they say. They will affect the cortex, but they will not affect the glomeruli or the blood vessels. Okay. What are the sign symptoms of acute pyelonephritis? The sign symptoms of acute pyelonephritis are clinical feature that the patient will complain of fever. The patient will complain of fever, flank pain, okay, flank pain. Patient can also complain of nausea, right? Vomiting, etc. But flank pain and fever, flank pain and fever, these two are very diagnostic of acute pyelonephritis. Okay, what are the now the thing is the thing which I wanted to talk to you guys about was how does it look like on a CT scan? Okay, how does it look like on a CT scan? CT scan, if you do a CT scan, then this would look something like, if I fail to draw this properly, we will go back to see how the actual drawing is. So let's say this is the CT scan of the kidney. Over here, you will see that there is striation. Okay, so this is the renal cortex. You will see that in the parenchyma, there will be striations. Okay, these striations, they represent inflammation and infiltrations of the renal interstitium. Okay, something more like this. This one, see this? There's striations. Okay, so that is your acute pyelonephritis, and this is extremely high yield for your U world. If you guys see a question where they tell you that CT scan is showing striations of parenchymal enhancement, then they are directing you to acute pyelonephritis. Okay, what are the risk factors? The risk factors are, once again, catheter, urinary tract obstructions, because the longer the urine stays, the more chance there is for the infection to happen. Vesico-ureteral reflux. Vesico-ureteral reflux, that is, if the urine has an backward flow from the bladder all the way up to the ureter, to the kidney, then that can cause acute pyelonephritis. And then you guys have diabetes and pregnancy. The complications of acute pyelonephritis, that is important. Acute pyelonephritis can move on to cause chronic pyelonephritis. There can also be renal papillary necrosis and perinephric abscess. Another thing is urosepsis. These are the four very well-known complications. Okay, if needed, try to remember these complications because questions can come directed from this or over here, which, but it's of a lesser high yield, so that's that. Okay, so these are the complications of acute pyelonephritis: chronic pyelonephritis, renal papillary necrosis, perinephric abscess, and urosepsis. We will discuss these in details in the future. Okay, next one is chronic pyelonephritis. What is chronic pyelonephritis? That is long-term or result of recurrent pyelonephritis or inadequately treated episodes of previous acute pyelonephritis can result in the formation of chronic pyelonephritis. This typically requires predisposition to infection, such as vesicular reflux or chronically obstructing kidney stones. Okay, these are not that high yield. The highest yield one is how will they present? Okay, they will present in your question is that they will have this diagram over here. They will tell you that the tubules contain eosinophilic casts resembling thyroid tissue. Okay, they will tell you that the tubules contain eosinophilic casts resembling thyroid tissue. This is known as thyroidization of the kidney. Thyroidization of the kidney. And so basically what would happen is, let's say that this is the renal system, renal tubule, okay? So in this tubule, you will have these small casts, like you will have this cast over here, okay? This cast, they will be eosinophilic casts, and they will resemble the thyroid tissue. And another thing is, this is what it looks like on microscopy, that you can see that there is thyroidization. You know, like how in a thyroid, this part looks like the follicle. This is exactly how the chronic pyelonephritis looks like, that you have these eosinophilic casts that look like that there are small pieces of thyroids in the kidney. Another thing is, how does it look like on macroscopy? Macroscopically, this looks like coarse asymmetric corticomedullary scarring or blunted calyx. Basically, there has been formation of fibrosis and scars due to the fact that it's a chronic inflammation. Chronic inflammation always results in fibrosis and scarring. So that's exactly what you see over here, that there is corticomedullary scarring and blunted of the, and there is blunting of the calyx. This is not that high yield, but the fact that tubules contain eosinophilic casts resembling thyroid tissue, that's more high yield. Okay, next one, another one is this is a very lesser high yield disease. That is xanthogranulomatous pyelonephritis. What is xanthogranulomatous pyelonephritis? It's a rare, grossly orange nodules that can mimic tumor. They're characterized by widespread kidney damage due to granulomas containing foamy macrophage associated with protease infection. I doubt you guys will ever receive any question from xanthogranulomatous pyelonephritis. If you guys do, please let us know so that we can be aware too. But if you guys have to understand what xanthogranulomatous pyelonephritis is that there could be granulomatous inflammation of the kidney due to protease infection. That's that. So that's exactly what it is. Are we clear about cystitis pyelonephritis? Okay. Not a lot of questions will be received from cystitis pyelonephritis. And then once again, it's very easy to understand. Okay. Next one. Next one is acute kidney injury. And then we have this one. Okay. Let's talk a little bit about AKI. Let's talk a little bit about AKI. First of all, what is acute kidney injury? What is acute kidney injury? In acute kidney injury, what we have is we have pre-renal, renal, and post-renal causes of acute kidney injury. First of all, if this is a kidney, okay. First of all, if this is a kidney, there are things that are happening, okay. So grossly, what I'm going to do is, okay, grossly, what I'm going to do is, let's say that this is the renal artery blood supply. Okay, let's say that this is a renal artery blood supply. Okay, this is obviously not how it looks like, but for your gross understanding, let's say that this is the renal artery. Okay, this is the kidney. Then this is the ureters, right? Then, well, what do we have over here? We have the bladder, right? Okay, so that's what it is. Now, there are three causes of acute kidney injury. First of all, there is pre-renal, renal, and post-renal. Okay, if we talk about pre-renal damages of kidney, if there is decreased blood supply, okay, if there is decreased blood supply to the renal artery to the kidney, will this cause decreased activity of the kidney or increased activity of the kidney? If we have decreased blood supply to any organ, okay, this will hamper the activity and the longevity of this organ. So basically, if we have decreased blood supply, now can we ask about some of the causes of decreased blood supply to the kidney? First of all, if we have a patient with decreased cardiac output due to shock, or if we have any patient who has heart failure, okay, dehydration, hypovolemia, burns, then excessive bleeding, right? So that's that. So these are some of the causes. What are the causes? Causes are decreased cardiac output and decreased blood volume. Okay, decreased cardiac output and decreased blood volume. Basically, if there's something wrong with the heart, that the heart cannot pump blood, or there is not enough blood. Very easy to understand that these are the two reasons for pre-renal causes of kidney failure. What are the renal causes of kidney failure? Renal causes of kidney failure could be, what are the renal causes of kidney failure? First of all, there could be infection, right? We can have acute long-term, we can have acute tubular necrosis. Okay, we can have acute tubular necrosis from infection, ischemia, sepsis, right? Then we can have interstitial nephritis, acute interstitial nephritis. These are some infection causes. Okay, pyelonephritis and chronic pyelonephritis, they usually do not cause kidney failure, but interstitial, if the renal interstitium is affected, then renal interstitium can spread, that infection can spread over wide to the kidneys very quick, and that can cause kidney failure. Same goes for ATN. ATN is a very dangerous condition because ATN is also a progressive infectious disease. So ATN and AIN. Next one is if we have any glomerular like condition. For example, if we have a nephritic syndrome, okay, long term, let's say we have acute glomerulonephritis, acute glomerulonephritis. That is also a very important condition. And then another one is if we have if we have certain other conditions. For example, if we have, let's say, sickle cell anemia, and then we have the sickle cell crisis in which the sickle cells are obstructing the kidneys, the tubules over here. That is one. Then we can also have thrombotic thrombocytopenic purpura, where there will be large formations of von Willebrand factors, right? Due to decreased atom TS13. They can also cause obstruction, and even in conditions such as malignant hypertension, right? So these are some other causes. So, but the main important causes are infection and glomerular like conditions. What are the some what are some post-renal causes? Post-renal causes are, first of all, if we have a kidney stone over here, okay, that is the number one. So first of all is stones. First of all is stones. Then then if we have cancer, okay, stones, cancer, 1 second. Okay, then if we have cancer, that can also be another cause. Okay, then what else? We can also have BPH. That can also be another cause. How is that happening? First of all, you have decreased flow of urine. Okay, so urine flow is decreased as a result of the kidneys. They can undergo hydronephrosis, as we have talked about. If there is hydronephrosis, they will push the cortex and medulla up towards the capsule because there's excess formation of the urine. And if it pushes everything up, then there could be kidney failure because urine cannot drain out because there's not enough space. So these are the causes. Okay, now what's happening over here is that if we write pre-renal, renal, and post-renal causes of kidney failure. So the causes are basically, for pre-renal is you have decreased blood supply. For renal, you have infection or glomerular-like condition or vascular-like conditions. For post-renal, you have stones, obstructions, and carcinomas. So these are the causes. Okay. Now let's talk about urine osmolality. Let's talk about urine osmolality. Okay. If we have pre-renal azotemia or pre-renal kidney failure, and then there is decreased formation of, there's decreased blood supply. Okay. If there's decreased blood supply, will there be increased GFR? Yes or no? Really need you guys to focus right now. Okay. Really need you guys to focus for this because this is very, very important. Very important thing to master. If we have decreased blood supply, the kidney will try to increase the GFR by constricting the efferent arterioles and this and that. But over time, what will happen is if the blood supply is not corrected, then GFR will obviously decrease. Okay, so there will be decreased amount of GFR. If GFR decreases, then will there be more urine or less urine? Less urine. If there is less concentration of the dilute of the solvent, will there be? But the kidney will still have increased amount of solute. Will there be high urinary osmolarity or low urinary osmolarity? Very good. Since the body does not have enough water, the kidney will try to reabsorb the water, and urinary reabsorption of water will, because the kidney will also try to maintain the blood volume by maintaining by the renin, angiotensin, aldosterone, and aldosterone will come and try to reabsorb the water, but at the same time, the solute in the kidney will increase. So it will be a thick. So if we have to talk about urinary osmolarity, it will be high. Okay, urinary osmolarity will be high. We will go to the values in 1 second. If we are talking about renal causes, for example, acute tubular necrosis, if we have renal causes, can the kidney perform the reabsorption functions very well? Yes or no? Because if the tubules are destroyed, then they can perform reabsorption. If they do not perform reabsorption, what will happen to the water content? Will they be high or will they be low? In the urine, the content of water. If the content of water is high, what happens to the osmolarity? will the osmolarity decrease or increase? Osmolarity will decrease. Very good. So urinary osmolarity will be low. The same thing happens for post-renal. For post-renal, the urinary osmolarity is also low. Okay, why is the urinary osmolarity for post-renal low? Because over here you have stones, cancer, and BPH, which is obstructing. As a result, the kidney, as a result, the urine backflows, and it causes dilatation. This causes pushing of the cortex and medulla, right? If the cortex and medullas are pushed, this puts pressure on the tubules, and when this puts pressures on the tubules, then they cannot concentrate the urine, right? Because there is decreased functioning of the cells in the tubules due to this excess accumulation of the urine. So that is the reason why in post-renal you also have decreased urinary osmolarity. Okay, next one. Next one is sodium in urine, urinary sodium. Because this is something to be worried about, because sodium is the number one ion that is involved for reabsorption, right? So if we have urinary sodium, first of all, is reabsorption intact over here in pre-renal azotemia, pre-renal failure? Yes or no? Yes. So if the absorption is intact, will there be more sodium in the urine or less sodium? More sodium in the urine or less sodium? Less sodium in the urine. Very good. Okay. How about in the renal one? Is reabsorption intact over here? Reabsorption intact? No. For example, in acute tubular necrosis, reabsorption is not intact. So will there be more sodium or less sodium? There will be more sodium. Very good. In post-renal one, this could be more, or this could be less, depending on reabsorption, okay? Because there is no direct damage to the tubules, like the one which happens in acute tubular necrosis, but still there is pushing of the of the cortex and medulla towards the outer capsule. If they can still perform the reabsorption function, then very well. If they cannot perform the reabsorption function, then obviously the sodium will increase, okay? Or they can stay normal, okay? As a result, fractional excretion of sodium, that is sodium filtered by sodium, sodium excreted by sodium filtered. If sodium is low, fractional excretion of sodium should also be low, and fractional excretion of sodium should also be high for this one, vice versa. And over here, once again, it will vary, okay? Let's talk about BUN and creatinine, okay? BUN and creatinine. For the serum BUN and creatinine, first of all, serum BUN and creatinine, uh, they are both reabsorbed. Okay, they are both reabsorbed. Basically, what happens is creatinine is BUN and creatinine. If the reabsorption function is intact, then BUN and creatinine level will be high. If the reabsorption function is, once again, is not intact, then the BUN and creatinine function will be low. Okay, and then over here they will vary once again. So that's exactly what's happening over here. So it all depends on the reabsorption function. For once again, for intact reabsorption, urinary osmolarity is high, sodium is low, FeNA is low, and BUN to creatinine is high. Then the exact opposite over comes and happens over here. Are we clear on the highs and lows? BUN and creatinine also depends on reabsorption. If it is intact reabsorption, then BUN and creatinine should not be reabsorbed. Okay, BUN and creatinine should not be reabsorbed. As a result, BUN and creatinine in the uh, BUN and my apologies. First of all, if reabsorption is intact, then BUN and creatinine should be high. Why should BUN and creatinine should be high in pre-renal azotemia? Because in pre-renal azotemia, you have the tubules which can perform the reabsorption functions. So as a result, as an indicator of decreased renal function, the pre-renal azotemia, the BUN and creatinine will be high. But in the renal system, in the renal azotemia or in the renal failure, what you have is you have the tubules which cannot perform the reabsorption functions very properly. So as a result, the serum BUN and creatinine will be low because they cannot reabsorb the creatinine or the waste materials at all, but the urinary BUN and creatinine will be high for the renal failure ones. Okay, so that's that. Have you guys understood pre-renal, intrinsic renal, and post-renal azotemia? Okay, no. Okay. Anyone else who has problems with pre-renal, renal, and post-renal? Fractional excretion of sodium. Do you guys remember fractional excretion of sodium? We did the equation that is sodium filtered by sodium, I mean sodium excreted by sodium filtered. That that one. Okay. Okay. Let's do another revision of the pre-renal, renal, and post-renal azotemia. First of all, pre-renal azotemia. Okay, let's talk about this one by one. Let's talk about pre-renal azotemia. What is the number one cause of pre-renal azotemia? Fast answers, please. What do you mean by pre-renal azotemia? Answer me this. Decreased, decreased cardiac output or decreased blood volume. Very good. If we have decreased cardiac output and decreased blood volume, will this result in a concentrated urine or a dilute urine? Concentrated urine or dilute urine? Concentrated urine. So the urine osmolarity should be high or should it be low? Okay. What about the reabsorption function of the kidney? Is it intact or not intact? Intact. If it's intact, then what should happen to the sodium in the urine? Should it be high or should it be low? It should be low, exactly. And the excretion of sodium, should it be high or should it be low? Should be low. Okay. What about the BUN to creatinine ratio? Since there's intact reabsorption, should be high. Very good. This should be very high. Okay. Okay. Next one. Next one is intrinsic renal failure. What are the causes of intrinsic renal failure? What are the causes of intrinsic renal? First of all, there is infection such as acute tubular necrosis, I mean inflammation, and acute interstitial inflammation. Can we also have some glomerular causes such as acute glomerulonephritis? Yes or no? Okay. Then what happens to the reabsorption function? Is this intact or not intact? Not intact. Okay. So what will happen to the urine? Will there be more water reabsorption or less water reabsorption? Okay. What happen to the urinary osmolarity as a result? Will it be high or will it be low? Okay. What happens to the urinary sodium? They cannot absorb the sodium, so the sodium in the urine should be high or low? High. Fractional excretion of sodium, should it be high or should it be low? What about the BUN to creatinine? Can there be proper reabsorption to represent the damage? No. So serum BUN and creatinine will also be low. Okay. And in post-renal, okay, in post-renal, do we have obstructions that are the main causes of post-renal? Yes or no? Yes. Will this push the renal cortex and medulla up towards the capsule because of accumulation of urine inside the kidney? Okay. Can this hamper the reabsorption function of the tubules if the tubules are compressed? Yes. Okay. So as a result, can the urine have low osmolarity too because the water reabsorption will not happen? Okay. So as a result, what happens to the urinary osmolarity in post-renal azotemia? Urinary osmolarity is low. Okay. And all the other ones they will vary. All the other ones, they will vary. Are we clear? Are we clear about this now? Okay, good. Okay. So next one that we want to move forward is are the values Okay. How do we understand the values? Okay. So the values at first, okay, the values that you will that are that we want to see is okay. First of all, can you guys tell me the normal urinary osmolarity? What is the normal urinary osmolarity? What is the normal urine osmolarity? Okay. Okay, let me write it down for you. The normal urinary osmolarity, random urine osmolarity should be around 800 to 850. 850 milliosmol. Okay, 850 milliosmol per kg of water. Okay, should be around more 850 or more than 850. 850 milliosmol per kg of water after a after a fluid restriction. Okay, so more than 500 will represent a very high urinary osmolarity. Okay, so the thing is, if we have if you have to remember these values, okay, the way that I used to do was okay, okay, 500, 20, 120. And what we would do is we would write down these values straight away after we write down osmolarity, sodium, fractional excretion of sodium, and serum, burn or creatinine. And then we would know that the osmolarity would be high, then urinary sodium should be low, FeNO should be low, serum BUN by creatinine should be high. So the thing is, we would try to keep in mind, or we would try to memorize these numbers. That's the unfortunate thing that you guys have to do too. And we would just try to memorize 500, 20, 20, 120, 500, 20, 120. Another thing that we would try to realize or try to memorize was 350, 40 to 15. That is 350, 40, 2, and 15. And if it's a renal cause, then if it's a renal cause, then it should be less than 350 urinary osmolarity. Urinary sodium should be high, so it should be more than 40. Fractional excretion of sodium should be high, more than 2. Serum creatinine should be low, so less than 50. So that's what we did. So unfortunately, you guys have to memorize these numbers too. Okay, there's not much that like we can make sense of this. There's not much that we can make sense of this, except the fact that you guys have to unfortunately memorize the number. So try to think of this as like a phone number. So 50020120120, 35040 basically. Unfortunately, that's the thing that you guys have to do. Okay, so can I give you guys, no, 850 is normal after 850 is normal after a 12-hour fluid restriction test. Okay, 850 should be the norm. 850 is the milliosmol for urine after a 12-hour water restriction test. Okay, and if it's more than 500 for like anyone who has not have had water restriction, then that is high for them. Are we clear? 800 should be 100 to 900. We had Dr. Iman over here. I think she wrote it down. 100 to 900 should be 100 to 900. Okay. So if we have more than 500, okay, should be around, okay, so close to 100. 1 second. So 100 to 900 should be considered normal, but if it's more than 500, then the urine osmolarity should be is considered to be high in a person who has not had water restriction test. Are we clear? Okay. So what was so can you guys try to will it be too much for me to ask if I ask you guys to remember the numbers 520, 120, and 340, 350, 40, 215? If you guys try to remember this, because you guys will be asked questions about this in your exam, and if you guys can remember the numbers, then it will be easy for you to answer those questions. Yes or no? Can you guys remember the numbers? Okay. So can I give you guys 1 minute, 1 to 2 minutes to read through the whole thing? Okay. I'll give you guys 1 to 2 minutes. Just read through the whole thing because this is very important. Okay. Acute kidney injury. This is very important. Okay. And the unfortunate thing is over here, you have to remember these numbers. So these numbers are very important because you will have questions directly coming from these numbers. So if you guys have these in your mind, then you guys can easily answer these questions. Okay, I'll give you guys 2 minutes. Okay, just read through the whole thing and then I'll ask you guys questions to see if you guys remember this or not. Okay, 2 minutes on the clock. It's 10:43. I'll ask you at 10:45. Okay, are you guys done? Is anyone still confused about the urinary osmolarity? How more than 500 is considered to be high? Is anyone still confused about urinary osmolarity? How more than 500 should be considered to be high? Creatinine, okay. Okay, good. What happens in serum creatinine? Serum creatinine for pre-renal, okay, serum creatinine for pre-renal should be high, and this should be low for the acute tubular necrosis. The reason being is in acute tubular necrosis, you do not have tubular reabsorption at all. So all the creatinine which gets filtered out, this does not get reabsorbed. So as a result, the creatinine in the blood is really low. But since reabsorption is intact in the pre-renal, that's why the serum creatinine is still very high. Okay, and also because of the reason that that during reabsorption, they also try to reabsorb a small amount of creatinine and BUN. All the creatinine and BUN is a metabolic product, and then kidney is not supposed to have reabsorptions of these things, but they still, since the reabsorption is still intact, that's what they do. But over here, decreased serum creatinine and BUN represents excessive loss of tubular reabsorption due to acute tubular necrosis. That's why this is low in the serum and high in the urine. Are we clear? BUN is blood urea nitrogen. Have you guys heard of? I'm pretty sure you guys have heard of BUN, right? Or have you guys not heard of BUN? BUN is blood urea nitrogen. Creatinine is creatinine. Okay. So let's say that you have BUN to creatinine. Okay. This is the ratio which they are usually, which they are trying to make you understand. Serum BUN to creatinine ratio. So more or less, it should be more than 20, and and it should be less than 15. So what's going on over here is that serum BUN to creatinine. Over here, what you have is you have decreased reabsorption of the serum. You have decreased reabsorption of the. I mean, you have increased reabsorption of the BUN. Okay, you have increased reabsorption of the BUN, but you have a bit less reabsorption of the creatinine. I mean, the urea reabsorption is intact, of course, because the reabsorption is still happening. But the creatinine reabsorption is also intact, but still, since it happens in a little amount, because creatinine is a waste product, since BUN is more reabsorbed, and creatinine was also reabsorbed in lesser amount, but it's still reabsorbed, you have high serum BUN to creatinine ratio that is more than 20. And over here, you have decreased BUN reabsorption and decreased creatinine reabsorption. Overall, the ratio that decreases. Are we clear now? Are we clear now? If you guys still have questions or confusions, please let me know. I will explain it again. I have no problem. I'll explain it 1,000 times, no problem. Okay, that's what I'm here to do. Okay, having said that, if you guys are confident about the, if you guys are confident about the numbers, then can I ask the numbers right now? Who is confident to answer me the numbers, please? Dr. Iman, who else? Who else? Okay, very good. Okay, so let's ask the pre-renal azotemia first. Urine osmolarity for pre-renal azotemia for Dr. Iman. Please write it down in the chat box. Fast. Pre-renal azotemia for, okay, very good. Then pre-renal osmolarity for azotemia is more than 500. Good. Then pre-renal urinary sodium. What's the value for pre-renal urinary sodium for Dr. Hussain? Less than 20. Okay. For pre-renal fractional excretion of sodium for Dr. Hossam. Fast answers, please. Pre-renal fractional excretion of sodium. 52120. Very good. Less. Next one is pre-renal serum BUN to creatinine ratio for Dr. Maheshwari. More than 20 or less than 20? BUN to creatinine ratio for pre-renal azotemia. Very good, Dr. More than 20. Okay. Next one is for everyone. Urine osmolarity for intrinsic renal failure. Everyone, fast answers, please. 350, 40, 250. Less than 350. Very good. Urinary sodium for intrinsic renal failure. Okay. Fractional excretion of sodium for intrinsic renal failure. And serum BUN to creatinine ratio for intrinsic renal failure. Okay. Are you guys watching Atoma videos? Every day you guys are supposed to watch videos. Okay, good. Okay, having said that, it's 10:53 as of right now. Do you guys want to take a break before we begin acute interstitial nephritis and ATN? Or do you want to take a break after that? Okay, so you guys want to take the break now. How long do you guys want to take the break? Okay, so we will take the break for 10 to 15 minutes. Then at 11, um, 11:10 a.m., we will begin our lecture. Okay. Okay, is everyone back from their break? It's exactly been 15 minutes. Are you guys back? Okay, good. Okay. So okay, so without further ado, let's begin. Can you guys see my screen? Okay, good. Okay. So let's start talking about acute tubular necrosis. So page 602, that's what we're going to begin with. What is acute tubular necrosis? We talked about this before. The most common cause is kidney injury in hospitalized patients. Spontaneously, this resolves in many cases. Okay, this can be fatal, especially during initial oliguric phase. So basically, acute tubular necrosis, they have three phases. Okay, these phases are extremely important to understand. One is the inciting phase when it begins. Then there's a maintenance phase. That is, during that phase, the patient is oliguric. The oliguria lasts for 1 to 3 weeks. Over here, you have risk of hyperkalemia, metabolic acidosis, and uremia. Most of the questions in U world that will come from the maintenance phase. If anyone asks you, at which stage do you think this patient is, if the patient is oliguric, then the answer is the phase is the second phase, that is the maintenance phase, because this phase is the oliguric phase. Over here, what is the highest risk? The highest risk is for the risk of hyperkalemia, metabolic acidosis. That is the two risks that's over here. Okay. Okay. Can anyone tell me why there's a risk of hyperkalemia? Can anyone tell me why there's a risk of hyperkalemia? No, we're not skipping nephritis. We will go back to nephritis after acute tubular necrosis. Okay, but can anyone tell me why we have hyperkalemia in acute tubular necrosis? Right. That is exactly what it is. There is loss of filtration, right? So since there is loss of proper filtration, so we have hyperkalemia, we have metabolic acidosis and uremia. Then we have a phase that is the recovery phase. In the recovery phase, the patients are usually polyuric. Okay, the BUN and serum creatinine they fall. Over here, what you have is you have a risk of hypokalemia because the kidneys they start working once again, and then there could be increased loss of potassium through the urine, and also there can be renal wasting of other electrolytes and minerals. So that's that. So out of all of this, if I have to ask you that if the proximal convolute, if the cells have to regenerate, what is the stem cell in the kidney that is responsible for regeneration of the tubules? Where are the stem cells of the kidney? This is a UL question. Where are the stem cells of kidney located? Everyone? Okay. Okay, so the stem cells are basically located at the proximal convoluted tubule, and the primary precursor is the metanephric blastema. The, the metanephric blastema is the precursor. So if the metanephric blastema is the precursor, then the primary stem cells are present in the proximal convoluted tubule. A small amount is also present in the distal convoluted tubule. But proximal convoluted tubular cells are the stem cells over there. That is a high yield question. What are the other causes of acute tubular necrosis? We have ischemia, then we have nephrotoxic. Ischemia is if we have decreased blood flow, if we have decreased renal blood flow, then obviously there could be damage to the tubules, which will result in the death of tubular cells, and that cells will slough off into the tubular lumen. Once again, what's going on over here is you have the lumen, okay, then you have this tubules, right, the proximal convoluted tubules. If there is ischemia, then there will be death. Okay, there will be death of the tubules. Okay, and after there's death of the tubule, they will slough off and then they will collect over here, right? So as a result, you can have this condition that is acute tubular necrosis. Another thing is you can have some drugs such as nephrotoxic drugs such as aminoglycoside, radiocontrast dyes, lead, cisplatin, and ethylene glycol. Okay, okay. So write it down in your, write this down beside your acute tubular necrosis. That you will have a question in your U world, okay, where they will tell you that you have a patient who is oliguric. The patient has urinary osmolarity that is more than 350. The patient has urinary sodium more than 40, FeNA is more than 2, okay, and blood urea and creatinine ratio is less than 15. And this patient has acute tubular necrosis. Okay, that's what you can diagnose from the question. But the thing is, they will tell you that this patient was undergoing a procedure of a cardiac catheterization followed by an insertion of a radiocontrast dye. If you ever hear a question of cardiac catheterization by the use of radiocontrast dyes, please consider the fact that that patient can have acute tubular necrosis. Did you guys write this down? Did you guys write it? Cardiac catheterization with radiocontrast dyes can result in acute tubular necrosis. You will come with a question where they will ask you what is the cause of acute tubular necrosis in this patient with cardiac catheterization. Your answer is radiocontrast dyes. Okay, you will come across this question at least multiple times in your U world. Okay, what are some other causes of acute tubular necrosis? That is crush injury, and that is in myoglobinuria, hemoglobinuria, and the proximal tubules are particularly susceptible to injury. Okay, so that's that. So the proximal tubules are the one which are more susceptible to injury. So that is acute tubular necrosis. Okay, over here, these are representing a cast. The casts are the granular cast, that is the muddy brown appearance. Okay, and over here you can see that this is the tubule, the renal tubules, and they are compacted by the sloughing off of proximal tubular cells. Okay, are we clear? Are we clear on those two images? Yes or no? Are we clear on those two images? One represents granular cast, and another one represents sloughing of tubular lumen. Are we clear? Okay, can I get some fast answers, yes or no, so that I know you guys have understood? If not, I will explain it once again. Okay. Acute tubular necrosis, once again, once again, if this is the tubule, okay, if this is the renal tubule, then this is the tubular cells, especially the proximal tubular cells. They can have damage, one by ischemia, another one by nephrotoxic drugs. Ischemia is by decreased blood flow, nephrotoxic drugs by drugs or toxin. I talked about a very high yield condition, that is cardiac catheterization, where they use radiocontrast dyes. If they do that, you will have sloughing off of these tubules. They will die, and then they will slough off, and they will compact over here. They will hamper the filtration process, and this will result in this will result in acute tubular necrosis. They have three phases, that is the inciting phase, maintenance phase, and the recovery phase. In the recovery phase, they recover from the stem cells in the proximal convoluted tubule and in the distal convoluted tubule. Okay, over here, this shows a granular cast. Over here, this shows sloughing of the proximal convoluted tubule. Are we clear now? Okay. Okay, let's talk a little bit more about acute interstitial nephritis. What is acute interstitial nephritis? This is also called tubular interstitial nephritis. This is one of the causes for the presence of the WBC casts in the urine. Okay, what you have over here is you have pyuria and azotemia, which will occur after administration of drugs that will act as haptin. Okay, so what is haptins? Haptins are basically, these are drugs that will induce an inflammatory reaction, and specifically the hypersensitivity reaction that is over here. That's what they will do. And what are the examples of drugs that can cause acute interstitial nephritis? Examples of the drugs are diuretics, NSAID, penicillin, PPI, rifampin, quinolones. Okay, how do we remember these drugs? These drugs are you can remember these drugs by the P's. P for diuretic, pain-free for NSAID, P for penicillin, P for PPI, P for rifampin, and one is S. Okay, S for the sulfur drugs. So if there's a patient, you will receive this question in your URL multiple times that you have a patient who has come with long use of analgesics for another condition. For example, for osteoarthritis, they have been taking ibuprofen for a long period of time. Now the patient is oliguric. The patient has increased serum creatinine. The patient has fever, rash, hematuria, pyuria, and renal ankle tenderness. Okay, so this patient, what is his problem? His problem is he has interstitial nephritis. Okay, and the reason is there is damage to the renal interstitium due to the NSAID. Okay, if there is if the patient has been taking NSAID, can you guys name the active metabolite that causes damage from NSAID? Yes or no? What is the name of the active metabolite that causes damage to the kidneys after a patient has NSAID? Wrong. PG for prostaglandin. Is that what it is? Okay. Have you guys ever heard of NAPQI? Have you guys ever heard of N-acetyl P-benzoquinone, NAPQI? It's for paracetamol, sure, but it's for paracetamol. It's for paracetamol, but paracetamol is also a very low yielding NSAID. It also prevents the activity of the cyclooxygenase pathway. And in NSAID, you also have some amount of formation of N-acetyl P-benzoquinone, which is an active metabolite that can cause damage to the renal interstitium. Are we clear? If you guys are asked about the active metabolite, what should be your answer? What should be your answer? NAPQI. Okay. 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 What are some other reasons that can cause? What are some other reasons that causes acute interstitial nephritis? We have infections such as mycoplasma, autoimmune diseases such as Sjogren syndrome, SLE, and sarcoidosis. Sarcoidosis. So these are some high yield causes of acute interstitial nephritis. Okay. How do you diagnose acute interstitial nephritis based on the clinical features? The diagnosis of acute interstitial nephritis could be done by fever. Okay, what we have is we have fever. Okay, then rash and hematuria. So this is a triad. Write this triad down in your book. Fever, rash, and hematuria. The first disease that you should think about is acute interstitial nephritis. Are we clear? Are we clear on this? Fever, rash, hematuria. Okay. Okay, perfect. Next one. Next one that we want to talk about is diffuse cortical necrosis. What is diffuse cortical necrosis? Diffuse cortical necrosis is exactly is a condition in which you have infarction of the renal cortex, renal cortical infarction. So you have infarction or decrease or obstruct or cessation of blood supply to the renal cortex, and this usually occurs due to a combination of two things. One is DIC, where there is accumulation and this causes decreased blood supply. Another one is vasospasm. The most high yield presentation of diffuse cortical necrosis is this is an event that occurs especially after obstetric catastrophes and septic shock. That is abruptio placenta and septic shock. And this is very high yield. If you have a patient that is a gynecological patient, okay, with sign symptoms of oliguria, flank tenderness, and the patient had a history of abruptio placenta or septic shock, then they are trying to direct you directly to diffuse cortical necrosis. Okay, obstructive, obstetric catastrophes and septic shock these are very high yield for diffuse cortical necrosis because in abruptio placenta and septic shock, you have a high chance of formation of disseminated intravascular coagulation, and disseminated intravascular coagulation will block the blood supply to the cortex because the renal cortex is highly supplied. So if you have a patient who has susceptibility of forming DIC, please consider the formation of diffuse cortical necrosis. Okay. Okay. Obstetric meaning what? Have you guys heard about gynecology and obstetrics? OBGYN. Okay. Gynecology is basically they deal with gynecological issues, right? They deal with fibroids and uterine conditions and vaginal conditions, cervical conditions. Obstetrician are the ones who are forming. Um, Obstetricians are the one who help out with your pregnancy, right? And then who help deliver the baby. They're more of the surgical. They're more on the surgical side of the OBGYN management. Okay, that is known as obstetrics. Obstetric. Okay, so obstetric catastrophes. Okay, next one is renal papillary necrosis. What is renal papillary necrosis? If there's sloughing of renal papilla, then there could be gross hematuria and proteinuria. So what's going on over here? You have the kidney, then you have, right, the renal pelvis. Okay. If you have if you have a renal papillary necrosis, then what they will do is that they will slough off, okay, and they will slough off, and then they will be collected over here, okay, and this sloughing off and this collection over here can what they do is they can cause an inflammation. Okay, this inflammation of the renal papillary sloughing off can cause damage to the glomerular basement membrane and to the podocytes. As a result, the patients can have hematuria and proteinuria, and this can be triggered by infection or immune stimulus or any type of inflammation that happens. Okay, what are the causes of papillary necrosis? This is very high yield, okay, because you have to diagnose, you have to have the ability to differentiate renal papillary necrosis, diffuse cortical necrosis, tubular necrosis, and interstitial inflammation. The ability to do that is very important. This usually occurs due to sickle cell disease, because in sickle cell disease, there is occlusive crisis, which can have decreased blood supply, acute pyelonephritis, analgesics are also another reason, and diabetes mellitus is also another reason. In diabetes mellitus, do we have decreased blood supply? Do we have end arteritis and decreased blood supply of little microvasculatures due to non-enzymatic glycations? Yes or no? Okay, and if there is decreased blood supply, then this can damage the renal papilla, and there can be sloughing off of the renal papilla. So that's what it is. Okay, now let me ask you very quick. Okay, let me ask you very quick. You have a patient who comes to you with a history of NSAID abuse. The patient has fever, rash, hematuria. What is your diagnosis? Fastest, please. What is your diagnosis? Okay. Do you have a patient who comes to you with formation of granular casts and muddy brown granular casts in the urine? Okay. Patient is oliguria. Very good. It's ATM. If you have a patient who has a history of abruptio placenta, okay, abruptio placenta and septic shock is your diagnosis. If you have a patient who has sickle cell anemia, what is the risk of the renal damage? It's called renal damage, renal papillary necrosis. Okay, renal papillary necrosis. If there is a patient who has a history of sickle cell anemia, that patient has a history of renal papillary necrosis. Okay, good. So these are the one. Can you guys okay, so can you guys write this down in your book in a short space like over here? Okay, write this down in your book. In this space over here, write this down. Write down NSAID abuse, AIN. Fast, please. We don't have a lot of time. We'll write down AIN is due to NSAID abuse. Done? Yes? No? good. Next, after that, write down obstetrical complication. Obstetrical complications. You have diffuse cortical necrosis, DCN. Write it down because this is exactly how the questions will be presented to you in your U world. Okay, done. Yes. Okay. Next one. Write it down. Next one. Um, Next one. Write it down as acute tubular necrosis will present with granular casts. And the next thing you will write is sickle cell anemia can result in RPN. Okay. Okay. You guys write it down? Yes or no? Okay, good. Okay, the next thing that we want to talk about is what are the consequences of renal failure? If we have a patient with renal failure, then obviously there will be a decrease in renal filtration. This can lead to excess retention of the nitrogenous waste product. What are the consequences of renal failure? First of all, number one consequence is metabolic acidosis. Okay. Okay, why do we have metabolic acidosis in renal failure? Why do we have metabolic acidosis in renal failure? Rarely. NSAID abuse can cause RPN, rarely. Sickle cell anemia is more associated with renal failure necrosis, at least for U world. Okay. Why do we have metabolic acidosis in renal failure? Okay. Excessive retention of hydrogen and decreased reabsorption of bicarbonate. Okay, that's your reason basically. Next one. Next one is dyslipidemia. Why? Due to especially there will be increase of triglycerides. Okay, there will be triglycerides that can be increased again due to again due to excessive retention of triglycerides. That's also that because the renal function is not working. High potassium, excessive retention of potassium. Then we can have uremia. Okay, how do you diagnose a patient with uremia? Uremia can be diagnosed by nausea, pericarditis, but the differentiating factors are asterixis, like flapping tremor, okay, encephalopathy, and platelet dysfunction. Okay, okay. When we were discussing UWorld nodes, do you guys remember we talked about uremia associated platelet dysfunction? Who remembers that? Who do we have a student who remembers uremia associated platelet dysfunction? What are the changes of platelet count, PC, BT, CT, and the factors? What happens over there? Do we have what are the factors? Very good. More or less all are normal. There should be no change. Okay. That's not a quantitative problem. It's a qualitative problem. So the only thing that should change is bleeding time. Okay. Please remember this. Please remember this. You guys will have questions regarding uremia associated platelet dysfunction multiple times where they will try to confuse uremia with DIC. They will try to confuse you with uremia and DIC, but you should have clear cut knowledge about the patient having uremia because the patient should have another sign symptoms of encephalopathy, asterixis, and a history of renal failure. Have you guys come across this question yet? Anyone? Anyone? Have you guys come across this question yet? Very good. Okay. If you guys have not come across this question, you guys have, and Dr. Jordan, Dr. Hussam, since you guys know what I'm talking about, so that's that. Okay. Another thing is you should also have salt and water retention, that is sodium and water retention, growth retardation, erythropoietin deficiency, and renal osteodystrophy. Okay. Over here, what we can do is you can try to remember the consequences, such as these consequences by the mnemonic mad hunger. Okay, but I do not really advise you to remember this because you will not be asked about the consequences directly. If you can understand why these things are happening, then there's no reason for you to remember this one, because you will not come across a question where they will ask you which one of these are the consequence of renal failure. This will never be a type of question of you. So don't worry about trying to remember these things. Just try to understand why they are happening, and this should be okay. Okay. Next one. We have two types of renal failure. One is an acute, that is an acute tubular necrosis, and chronic. Chronic is long term. For example, due to diabetes mellitus, due to hyperfiltration damage, right? Hypertension, which can cause high hyalinizations of the arteries, and any other congenital anomalies such as polycystic kidney diseases. Those are another types of causes of chronic renal failure. Okay, and you have reductions in GFR in all stages of CKD, and the CKD GFR decrease. Can you guys tell me how many stages there are in CKD? How many stages do we have in CKD? 5 stages. Okay. You do not have to remember for which stage what GFR is for the step one. Okay, that's for step two. Okay, next one. Next one is renal osteodystrophy. Okay, who remembers renal osteodystrophy very well? We discussed about this multiple times when we had endocrinology. Okay, 5 stages of CKD. Okay, okay, Dr. Hussam, would you be kind enough to unmute yourself and answer what do you remember about renal osteodystrophy? Fast, please.
Okay, so we have loss of renal function,
Mhm.
so no synthesis of vitamin D. So
Okay,
there will
why?
be
One
loss
second.
of,
No, no,
yeah,
1 second. Why do we have no synthesis of vitamin D due to loss of which enzyme at which
due to loss of alpha 1 hydroxylase
one alpha?
enzyme
With what is the site?
uh, in proximal convoluted tubules,
Okay,
proximal
then
convoluted cells.
okay, then what happens?
Then there will be loss of negative feedback
Okay,
with parathyroid gland.
okay,
So parathyroid hormone will be increased,
okay.
and due to that, parathyroid hormone will be like act much on bones tissue. So the final net result, activation of osteoclasts, so bone resorption and fibers deposit in the bone. So
Very good.
that's it.
Okay, so more or less you have mentioned everything. Thank you so much, Dr. Hussam. Has everyone understood renal osteodystrophy, or do I repeat renal osteodystrophy one more time? Very easy to understand. Repeat or repeat? Okay. Renal osteodystrophy. What's going on over here? You over here, okay, what you have is you have an enzyme which is called 1 alpha hydroxylase in the proximal convoluted tubule, which transforms vitamin D from its pre-active form to the active form. After vitamin D is formed, the vitamin D goes to the gut. Vitamin D goes to the gut, and it increases the reabsorption of the calcium. So calcium reabsorption occurs. But over here, since 1 alpha hydroxylase is not working due to renal failure, you have low vitamin D. So low amount of calcium is being reabsorbed. As a result, serum calcium is low. When serum calcium is low, you have the release of a very high yield hormone, which is parathyroid hormone. Parathyroid hormone is released. Parathyroid hormone, which is released, it causes increased activity of the osteoclast for bone resorption, and this bone resorption results in the formation of osteitis fibrosa cystica, where there is fibrosis, and then there is release of the bones. I mean, there's release of the calcium by the action of osteoclast activated by the parathyroid hormone. So this results in bone pain. This bone pain due to renal cause is known as renal osteodystrophy. Okay, so that's exactly what happens. So you have hypocalcemia, hyperphosphatemia, right, and failure of vitamin D hydroxylation. This results in hyperparathyroidism, and this high serum phosphate can bind with the calcium, and this will decrease the serum calcium level.
And as a result, you'll have decreased intestinal calcium absorption due to decreased formation of vitamin D. And this is known as renal osteodystrophy because this is exactly what you can also see in osteitis fibrosis cystica, that is subperiosteal thinning of bones. Okay, are we clear on this? Are we clear on this? Okay, very easy to understand. Okay, next one. Next one is renal cystic disorders. What are the renal cystic disorders? First of all, you have autosomal dominant, autosomal recessive, autosomal dominant tubular interstitial, and simple versus complex renal cyst. Let's talk a little bit about autosomal dominant polycystic kidney. This is a condition in which there are numerous cysts in the cortex and the medulla. This will cause bilateral enlargement of the kidneys and ultimately destroy the kidney parenchyma. Okay, what will the patient complain about? What will the patient complain about with autosomal dominant polycystic kidney disease? The patients will usually complain about, what they will tell you is that they have flank pain, heaviness, hypertension, urinary infection. They can also tell you that they have hematuria, right? And progressive renal failure. So that is very high yield. Okay. What is the gene that is responsible for causing the autosomal dominant polycystic kidney disease? Yesterday we mentioned this gene. Do you guys remember PKD1 and PKD2 in UWorld notes? Okay. Yes or no? Do you guys remember we mentioned PKD1? What's the chromosome number? PKD1. What is the chromosome number for PKD1? Okay. What is the chromosome number for PKD2? Okay. So PKD1 and PKD2 for chromosome number 16 and 14 respectively. So PKD1 is more common, which is the chromosome on chromosome number 16, which is defective. And for PKD2, you have on chromosome number 4, which is less common. Okay. So the way that Dr. Hossein Sattar tries to describe this in pathoma is that he says that whenever you have a dominant polycystic kidney disease, try to think about cysts in many places. Okay, first of all, if you have a cyst in the brain, that is cystic enlargement of a blood vessel, then you can have berry aneurysm. If you have the mitral valve, which is prolapse, then that also appears like a bulge, like this, which can have a cystic appearance. So cyst in the heart for mitral valve prolapse. Then if you have cysts in the liver, this is fortunately called benign hepatic cysts. If you have air-filled pouches or cystic appearance of the large intestine, this is known as diverticulosis. If you have cystic appearance of the cysts in the kidneys, this is called autosomal dominant polycystic kidney disease. Okay, so try to think about all the cysts in autosomal dominant polycystic kidney disease. First of all, if I tell you that you have a cystic appearance of the blood vessel in the brain, what is the association? Fast answer. Fast answers, please. Well, what is the association? Very aneurysm. Okay. If you have cystic appearance of a valve in heart, what is the association with autosomal dominant? Very good. If you have cystic appearance in the liver, what is the association? Cystic appearance in the liver, benign hepatic cysts. Very good. If you have cystic appearance in the air-filled pouches in the walls of the intestine, what is the association? Diverticulosis. If you have cystic appearance of the cyst in the kidney, what is the association? Okay, so basically, all dominant polycystic kidney disease can have berry aneurysm, mitral valve prolapse, hepatic cysts, and diverticulosis. That's what I want you guys to understand. Okay, are we clear on this? Okay. Treatment is if there's hypertension or proteinuria which will develop, we have to treat it with ACE inhibitors or ARB, right? So that's that. The treatment is very normal, and obviously this is a surgical complication, so this has to be performed. The surgery that has to be performed is bilateral or unilateral nephrectomy, followed by kidney transplant if bilateral, and if unilateral, then no kidney transplant. So that's that. Okay. Next one is autosomal recessive polycystic kidney disease. Autosomal recessive polycystic kidney disease is cystic dilatation of the collecting duct. Keep in mind that you have cysts in the cortex and medulla of autosomal dominant polycystic kidney disease. For recessive polycystic kidney disease, these are cystic dilatation of the collecting ducts. Okay, and they usually occur in in infants and in the young population. Okay, and over here you have an association of hepatic fibrosis that occurs, and the concerns beyond neonatal period will include systemic hypertension, progressive renal insufficiency, and portal hypertension from congenital hepatic fibrosis. So basically, if you have cysts in the kidney of young children, then obviously, due to this will hamper the blood supply. If this hampers the blood supply, this can activate the renin, angiotensin, aldosterone, and young children can have hypertension. And with hypertension, they can have progressive renal failure due to that hypertension. And also the fact that these happens with these take place with hepatic fibrosis, the patients can also have portal hypertension. Okay, so that's that. Next one is autosomal dominant tubulointerstitial kidney disease. Before we jump into this, highest yield is autosomal dominant polycystic kidney disease. Okay, what are the questions? This is one question. This is another question. And this is another question. PKD chromosomes. Then you have associations. Autosomal recessive is less yield. Okay, you will receive one or two questions. They want to know that if you understand that there is dilatation of the collecting ducts. That's all. Okay, so there is only one question. Next one is medullary cystic kidney disease. This is also very less high yield. Okay, you will have progressive renal insufficiency with inability to concentrate the urine. Okay, and they're usually small cysts on ultrasonogram, and they have a very poor prognosis. Basically, they will cause basically what they will cause is they will cause progressive renal failure. But the thing is, this is a bit uncommon because they will not ask you these questions about medullary cystic kidney disease very frequently because the sign symptoms will overlap with all the other sign symptoms. But the best way that you can diagnose medullary cystic kidney disease are two things. First of all, the patients will have cysts and the patient will have small kidney. Okay, small kidney. If I tell you the patient has multiple cysts and the kidneys are large, what is your diagnosis? Multiple cysts and large kidneys. What is your diagnosis? Right. If I tell you that the patient has small cysts and it's a small kidney, then what is your diagnosis? Small cysts and small kidneys. Very good. Now I want you guys to write this down in your book. Over here, we'll write this down. Multiple cyst, large kidneys, autosomal dominant. Small cyst, small kidney, autosomal dominant tubulointerstitial kidney disease. That's how you can differentiate them. Okay, write it down and let me know. Write done. Write done after you are done writing the notes. Yes, of course. Okay, so Dr. Osam, can we? Okay, of course I can. It's multiple cysts, large kidneys, autosomal dominant polycystic kidney disease. Small cysts and small kidneys, that is autosomal dominant tubulointerstitial kidney disease. Okay. Okay, good. Okay, next one. Next one that we want to discuss is renal vascular diseases. Renal vascular disease. So what is renal vascular disease? We have renal impairment due to ischemia from renal artery stenosis or microvascular diseases. Okay, so what this is very important. I'm going to tell you why, because This, if I tell you, okay, wait for a minute. Let's get this understood first. Okay. Okay. Afferent arteriole, efferent arteriole. Okay. If we have a plaque over here, will there be more blood supply or less blood supply to the through the afferent and efferent arteriole? Less. So there will be less of this renal perfusion. As a result, can the patients have more renin and or less renin? More renin. As a result, will the patients have hypertension or hypotension? Hypertension. Very good. The two causes of these type of renal vascular diseases, number one is atherosclerosis, another one is fibromuscular dysplasia. Fibromuscular dysplasia. Now, the thing is, okay, now that the thing is, the renal artery that is going through over here, atherosclerosis will affect the proximal one third, and the distal two third will be affected by fibromuscular dysplasia. And the atherosclerosis, once again, is more common in males. Fibromuscular dysplasia is more common in females. Another thing that you can write down is you can find a pulsatile abdominal mass. You can also find a pulsatile abdominal mass. We'll write it down in your book. Pulsatile abdominal mass that can also represent, okay, you can also expect to find a pulsatile abdominal mass in renal vascular diseases. Clinically, the patients can have refractory hypertension with a history, negative history of family hypertension. So the thing is, these patients will be in like early, late 30s or early 40s, such as 35, 36, or 45, and they can have, they can have hypertension with a history of family hypertension. So the thing is, can have uncontrolled hypertension Can you guys hear my voice? Yes or no? How about now? Is the voice better now? Is the voice better now? Okay. Okay. So if you have a male patient, if you have a male patient and he has an atherosclerotic plaque, okay, where is the location? Where is the location of the plaque? Male with fibromuscular dysplasia, where is the location? Distal third. Okay. Okay, can you guys hear my voice now? Can you guys hear my voice now? Okay, good. So if you have a young patient, close to around 35, 36, with hypertension that is 160 over 100, the patient has no problems with the arterial or any cardiac problem. What will you suspect in these patients if it's a female patient? Fibromuscular dysplasia. Very good. Okay. And so that's exactly what we have to keep your mind open for. Fibromuscular dysplasia. Okay. The next thing that we want to discuss is renal cell carcinoma. One second. The next thing that we want to discuss is renal cell carcinoma. Okay. So what is renal cell carcinoma? Renal cell carcinoma is basically, what is renal cell carcinoma? This is basically primary carcinoma of the kidneys. Okay. The number one way you can diagnose a renal cell carcinoma is the presence of this cholesterol-like, okay, this lipid clefts. Okay. So this is a very high yield drawing. This is a very high yield diagram for your exam, is because they will tell you that you have a patient who has flank tenderness or hypertension or weight loss, and then on biopsy they found I mean, on examination the kidneys are palatable, and then on CT scan you see a kidney like this. Okay. Then you do a biopsy. On biopsy, you find that the kidneys have these clefts, this lipid-like clefts in the renals in the kidneys. If that's what it is, then your primary diagnosis should be renal cell carcinoma. This should be confirmed by the presence of the lipid-like clefts. Okay.
Repeat, please, doctor.
Okay. Okay. What is renal cell carcinoma? First of all, renal cell carcinoma is your polygonal clear cells. They're filled with lipids and carbohydrates. Okay. The number one way you can diagnose this is this by, let's say, first step by step. You have a patient who will come to you with unilateral flank tenderness, heaviness, hematuria, weight loss, hypertension. Okay. After that, you perform an examination. You find the kidneys are palatable. Okay, you suspect the patient might have carcinoma based on the fact that the patient has weight loss and hematuria. You do a CT scan, and on the CT scan you see an image which shows a lesion, and then you perform a biopsy of the kidney. After you perform a biopsy on histopathological examination, you find that there are polyclonal cells like this, which has lipid clefts of lipid, like this one, clefts of lipid. This look like lipid cells. Then you can confirm the patient has renal cell carcinoma. After that, you have to do nephrectomy, unilateral nephrectomy, and or bilateral nephrectomy, followed by kidney transplant. Okay. Where do these carcinomas arise from? They arise from the proximal convoluted tubule. Okay. Do you guys remember we said that the proximal convoluted tubule contains the stem cells of the kidneys? Yes or no? Stem cells of the kidneys. Okay, if the proximal convoluted tubule contains the stem cells of the kidneys, then they are highly susceptible to undergo multiplications, right? Cellular division and multiplication process. If that's what they go through, if that's what they go through, then these cells which are actively dividing, they have a higher chance of undergoing undergoing carcinomas, of undergoing of undergoing in the process of forming a carcinoma. That's what it is. And these carcinomas, they have a hematogenous spread, meaning that they can be spread via blood, and the metastases are usually to the lungs and to the bones. Okay. What are the sign symptoms? The patient will come and complain of hematuria, palpable mass, flank pain, and on signs you will see that the patient has polycythemia due to excessive erythropoietin formation. Over here you will have carcinoma, so there will be excessive formation of erythropoietin by the peritubular cells. The treatment is usually surgery followed by immunotherapy. Okay, what immunotherapy can we give? The immunotherapy we can give is Aldesleukin. Aldesleukin, this is highly important for MBOS, for students who are solving MBOS. They will be asked about this. And they're resistant to chemotherapy and radiation therapy. So there's no scope of giving chemo or radiation. Uh, the renal cell carcinoma is the number one renal malignancy. Common age is between 50 to 70 years of age. Okay. There are some paraneoplastic conditions associated with the carcinoma. That is parathyroid related peptides, ectopic erythropoietin, ACTH, and renin. So peers. Okay, we discussed about this in the U world. So you will have excessive erythropoietin, parathyroid hormone related peptide, ACTH, and renin. Okay. Now, what is the chromosome that is what is the chromosome number that is associated with renal cell carcinoma? We discussed about this in neurocutaneous disorders. Have you guys seen our video on neurocutaneous disorders? Yes or no? Okay. Over there, we discussed about a very important disease. What's the name of the disease? If you guys have not seen the neurocutaneous disorder, it's there on our YouTube channel for free. Just write neurocutaneous disorder by Dr. Haidari, or go to Dr. Haidari and write neurocutaneous disorders. You'll come up with the video. It's a 15-minute video. It's a very helpful video to help you understand how to answer every question from the neurocutaneous chapter. And the condition that we wanted to talk to you about is von Hippel-Lindau syndrome, von Hippel-Lindau, VHL. The VHL is for chromosome number 3, and that's that. Okay, what are the other things that you can see in a patient with von Hippel-Lindau? For the students who has watched my videos, this question is for you. What are the other things you can find in a patient with von Hippel-Lindau? Hemangioma, cerebral angioma, okay. Then, right, hemangioblastoma, pheochromocytoma, angiomatosis, and renal cell carcinoma. Very good. So these 4 things are what exactly that happens in von Hippel-Lindau. Next thing that we want to discuss is renal oncocytoma. Renal oncocytoma is a benign cell tumor which will arise from the collecting ducts. So once again, okay, you guys want to draw this down in your book. Okay. So over here, if you have carcinoma arising from this part, this is most probably renal cell carcinoma. If you have a tumor arising from this part, that is from the collecting ducts, this is usually a benign tumor, which is oncocytoma. Okay. Did you guys draw this down? Yes or no? Did you guys draw that down? If you have carcinoma or tumor arising from the proximal convoluted tubule, it's highly likely it's renal cell carcinoma. If you have these arising from the collecting duct, it's highly likely it's oncocytoma. Okay. Are we clear? Okay, very good. Okay, so that's what it is. Okay. Now the thing is, these are benign tumors that will arise from the collecting ducts. They are well circumcised. That is how the presentation of a benign tumor should be: well circumcised, intact capsule, no intact capsule, well circumcised, not growing, no invasion. Okay, these are all the signs. These are all the properties of a benign tumor. If you do a histology, how will they appear? They will appear as large eosinophilic cells with abundant mitochondria. As you can see that there are large eosinophilic cells with abundance of mitochondria without perinuclear clearing. So there will not be any perinuclear clearing. And this is exactly how they will describe this to you in your UWorld. Okay, so how will they look like if I have to draw it out? Okay, so you will have this large eosinophilic cells, okay, with a lot of mitochondria, and usually there is perinuclear clearing. Let's say if this is the nucleus, then there's clearing around the nucleus, but there is no perinuclear clearing. So if you have large eosinophilic cells with abundant mitochondria without perinuclear clearing, this is a highly descriptive and diagnostic of a renal oncocytoma. What are the sign symptoms? Sign symptoms are abdominal mass, hematuri, and flank pain. Okay, do we do a biopsy of renal oncocytoma? Yes or no? Do we do a biopsy of renal oncocytoma? Of course, we do a biopsy of renal oncocytoma. How else will you know if it's malignant or not malignant? Okay. How else will you know this is malignant or not malignant if you do not do a biopsy? So once again, do we do a biopsy of renal oncocytoma? Do we resect the organ? Okay. Okay. Do you do a biopsy of hemangioma? Why? How else will you know it's malignant or not malignant? How else will you know if it's hemangioma or hemangiosarcoma? How would you know? Okay, so how do you treat a hemangioma if you don't do a biopsy? Okay, you guys are right. You guys are absolutely correct. We do not do a biopsy for hemangioma because there's risk of bleeding. So what we do for hemangioma is no, we do not do imaging. What we do for hemangioma is for hemangioma, let's say that this is a hemangioma, benign tumor of the blood vessel. What we do is if it's a tumor, right, benign tumor, so it should be something like this. Every tumor has a capsule. Okay. So your goal as a surgeon is not to do a biopsy, but your goal as a surgeon is to resect the whole thing with entire capsule. You want to make sure the capsule is intact. Okay. Are we clear? Take it off with the capsule. That is what you will do. And if you do that, then you can do a biopsy and then you can see if it's a carcinoma or just a benign tumor. Are we clear? Okay. Nope. What is the difference between resection and biopsy? Resection followed by histopathology is resection of the entire thing. Biopsy is taking a small piece of tissue. Are we clear? Are we clear? Biopsy is taking a small piece of tissue to see if it's to see the characteristic of the tissue. Okay, can you guys hear my voice? Is the voice clear? Okay, good. Okay, my apologies. Okay, once again, what is the difference between biopsy and resection? What is the difference between biopsy and resection? Biopsy is taking a small piece of tissue, okay, and resection is taking the entire tissue out. So that is resection, okay? Okay, good. Next one, next thing that we want to discuss is, okay, the next thing that we want to discuss. Okay, so are we clear about renal oncocytoma? Are we clear about renal oncocytoma? Okay, So next time you guys find a question regarding renal oncocytoma, where is the tumor arising from? Where is the tumor arising from? Collecting duct. If you have a renal cell carcinoma, where is the tumor arising from? Proximal convoluted tubule. Okay, proximal convoluted tubule. Very good. Okay, good. Yes, you have to do biopsy in oncocytoma. You can do a biopsy or you can resect. Okay. Okay. Okay, good. Are we ready to move on? Are we ready to move on? Yes? Okay, good. Okay. The next thing that I want to discuss with you guys, okay, the next thing that I want to discuss with you guys is nephroblastoma. So what is nephroblastoma? Nephroblastoma is also called Wilms tumor. Okay, nephroblastoma is also called Wilms tumor. Okay, what happens in nephroblastoma is, in nephroblastoma, this is a tumor of young children. Okay, this is the most common renal malignancy. Okay, and what happens is you have glomerular structure. What happens is you have glomerular structures over here, which have which basically has the carcinoma. So basically, if you look at this CT scan over here, you can see that you can see that you can see that there's a large mass over here in the tumor of a young child. If you see any tumors like this, then it is one second, please. Okay, so can you guys hear my voice and see my screen? Can you guys hear
Here's
my
a Google result.
Can you guys hear my voice and see my screen? Okay, good. Okay, yeah, good. Okay, so what I wanted to do was, okay, so this is basically nephroblastoma. So this is called a Wilms tumor because this is the most common renal malignancy of the early childhood. They contain embryonic glomerular structure, right? They present with large, palpable unilateral flank mass and hematuria. Okay, so what I wanted to talk to you guys about was, okay, what is the, one second, okay, what is the chromosome? What is the name of the chromosome number? What is the name of the chromosome? The name of the chromosome is WT1. The name of the chromosome is WT1 or WT2. The name of the chromosome is WT1 or WT2. The WT1 and WT2, they can be present on a chromosome. Then do you guys know which chromosome this is present on? What is the chromosome number for Wilms tumor? Very good. Okay. How many, okay. How many words do we have in this Wilms? 1, 2, 3, 4, 5. Okay. Tumor. TUMO 6, 7, 8, 9, 10, 11. So how many words for Wilms tumor? How many words for Wilms tumor? 11. So what's the chromosome number? What's the chromosome number? 11. Will you guys ever forget this ever? Because very good. Okay, so Wilms tumor has 11 letters for chromosome number 11. And Wilms tumor WT1 and WT2. Okay,
there are two other things which I wanted to talk to you about. That is some syndromes. Okay, what are the syndromes that are associated with Wilms tumor? First of all, we have this one syndrome which is called WAGR syndrome. WAGR stands for Wilms tumor. Then it stands for aniridia, and we have to spell tumor, not tumor. Can you spell the tumor and Wilms tumor with a U, please? So that it actually becomes the number 11. Okay, because that will actually help you remember. That's why we spell it with a U, not with an O. Is that okay? Okay, this is, we understand, we know that the spelling of tumor should be with an O, but we spell it with a Y for just to remember, nothing else. Okay, okay. So for the Wilms tumor, please spell it with a U. Okay. Now let's move on to the first syndrome. First syndrome is WAGR syndrome. WAGR syndrome contains Wilms tumor and iridia. Then you have genitourinary malformations. And another thing that you have is mental retardations. Okay. So the main problem over here is Wilms tumor. Along with this, if a patient has aniridia, meaning absence of iris, genitourinary malformation, and then they also have mental retardation. These patients have the syndrome WGR due to absence of WT1 or absence or deletion of WT1. Okay, this is very high yield. The next syndrome that we want to talk about is Dennis-Grash syndrome. Dennis-Grash syndrome. What is Dennis-Grash syndrome? Dennis-Grash syndrome. Okay. Okay. First of all, let's talk about this one, WAGR. Okay. WAGR syndrome. Okay. So we have this one friend. Okay. This is this friend of ours. Okay. He apparently has multiple problems. This friend of ours has um this friend of ours has a large kidney. Okay. Unfortunately, this friend is blind. Okay. This friend is blind in one eye. This friend has this friend has a genitourinary malformation, and this friend is has some sort of a mental retardation. The friend has a hard time going through school. So this friend over here with aniridia, then we have genitourinary malformations, Wilms tumor, mental retardation. This is your WAGR syndrome. Okay, excuse me. This is WAGR syndrome. This is occurring due to WT1 deletion. The next one that we have is Dennis-Grash syndrome. Dennis-Grash syndrome is everything with the D and Wilms tumor. So first of all, these patients will have a Wilms tumor. Along with this, the first D is diffuse mesangial sclerosis. So do you guys remember the mesangium in the kidney? Yes or no? Do you guys remember the mesangium? These were these cells over here. Okay. If there's scarring and sclerosis and there's 50%, more than 50% involvement of all the mesangium, then this is known as diffuse mesangial sclerosis. These patients will have problem with GFR, with the filtrations. Okay. Another one is dysgenesis of the gonads. So gonadal dysgenesis. And Dennis-Grash, this occurs not due to absence. This occurs due to mutation of WT1. WT1 is mutated, not absent. So mutation. If there is absence, then there will be Wilms tumor with aniridia. And if there is mutation, then there will be Wilms tumor with diffuse mesangial sclerosis and your gonadal dysgenesis. Are we clear on this? Yes or no? Are we clear on this? Okay.
Doctor, I have a question. So Dennis Drash syndrome will be only in male?
Dennis-Drash syndrome can be in men and women.
Thank you.
Okay, could be in men or women. Okay, once again, WT1 deletion, WAGR, WT1 mutation, Dennis-Drash. What is WAGR? It's Wilms tumor, aniridia, genitourinary malformation, and mental retardation. What is Dennis-Drash? Dennis-Drash is WT1 mutation resulting in gonadal dysgenesis and diffuse mesangial sclerosis and Wilms tumor. Okay, okay, okay. Next one. Next one that we will discuss is okay. The next one that we will discuss is Beckwith-Widman syndrome. Okay. Next one that we will discuss is Beckwith-Widman syndrome. What is Beckwith-Widman syndrome? Over here you have WT2 mutation. You have mutations of WT2, not absence. You have mutation. This in my drawings are representing mutation. This is for absence. Okay. So you have a WT2 mutation. Okay, WT2 mutation. So what's happening over here is you have Wilms tumor. Okay, so we can draw this guy out. This guy has a Wilms tumor. Okay, along with this guy has macroglossia, 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 meaning a large tongue, large protruded tongue. Okay. Then, and another thing that this guy has is, okay, this guy has an omphalocele. How do we draw that? How do we draw an omphalocele? Okay, like a small pouch over here. Okay, omphalocele. Another thing that this guy has is hemihyperplasia. This guy has hemihyperplasia. Does anyone know what hemihyperplasia is? What is hemihyperplasia? This is basically enlargement of one side of the body. Okay, so one side of the body is enlarged. Okay, hemihyperplasia. So basically one side of the body is enlarged, that is hemihyperplasia. Okay, one second. You see this? This is called hemihyper. This is called hemihyperplasia. One side is bigger than the other. Okay, are we clear? Are we clear? Are we clear on this? Okay, so this is hemihyperplasia. Okay, having said that, okay, the next thing that we want to discuss are uh, two more things. Okay, so this is what we just discussed: WAGR, Dennis-Drash, and Beckwith-Widman. Please go through this once again. I will give you time. I will give you guys time to understand this, and then I'll ask you questions. No problem. Next thing that we want to discuss is urothelial carcinoma of the bladder. What is urothelial carcinoma? This is also called transitional cell carcinoma. This can be seen in renal, callus, pelvis, and ureter. The most high yield point is the reasons for your transitional cell carcinoma. Number one is phenacetin. Number two is smoking. How does smoking cause transitional cell carcinoma? Smoking has nitrogenous substances, right? Those nitrogenous substances, when they are inhaled through the lungs, they travel all the way to the urine and to the bladder, right? And the toxins and nitrogenous substances, they irritate the walls of the bladder, and chronic irritation can result in the formation of dysgenesis, and then you can have carcinomas, right? You can have carcinoma, dysplasia, right? You have metaplasia, dysplasia, then carcinoma. Another things that can cause your urothelial carcinomas that are aniline dyes and cyclophosphamide. So these are, so out of here, just try to remember smoking for transitional cell carcinoma. How do they look like? They have a fibrovascular core surrounded by a dysplastic urothelium. Okay, this picture is not that high yield. You will not receive a lot of questions from over here, but the association is they'll only ask you what is the risk factor. Risk factor is smoking. Another one is squamous cell carcinoma of the bladder. The most high yield risk factor for squamous cell carcinoma is the parasite called Cystosoma hematobium. Okay, do we have any students over here from the Middle East or Europe? Okay. We talked about this before. Okay, if your friends want to go for a swim in the lake, would you warn them about schistosomiasis? Swimming in the lake in Egypt or Europe? Yes, you should warn them. You should warn them because they have schistosoma hematobium, which can cause your squamous cell carcinoma. They can also cause cystitis. Cystitis can also be a reason, but this is very rare. But smoking and schistosoma hematobium is a very important cause for squamous cell carcinoma. And the presentation is basically painless hematuria. There will be painless hematuria. Okay, are we clear on this? Okay. Okay, with that being said, we are done with renal pathology. Okay, with that being said, we are done with renal pathology. We only have close to around half an hour to 1 hour. Do you guys want to stop here and start pharmacology from tomorrow? Okay. How much is considered NSAID abuse? Okay, you are, as an adult, you can have a total of not more than 2,500 25. Um, I mean, you cannot have more than 2.5 grams per day. Okay, you cannot have more than 2.5 grams per day. Okay, so if you have more than 2.5 grams per day for a long period of time, then you can have NSAID abuse. Okay, so 2.5 grams. Okay, more than 2.5 grams can be dangerous. Nephroblastoma is basically Wilms tumor. Wilms tumor is present in childhood. The chromosome number is 11 because Wilms tumor is spelled with 11 letters with an addition of U. If you have Wilms tumor with absence of iris and mental retardation, it's called WAGR. If you have Wilms tumor with gonadal dysgenesis and diffuse mesangial sclerosis, it's called Dennis-Drash. If you have Wilms tumor with macroglossia and hemihyperplasia, it's called Beckwith-Whitman syndrome. Okay. Acetaminophen is a low potent NSAID. Okay, it's a low potent NSAID, but there's a difference in their mechanism of action. One will bind reversibly, another one will bind irreversibly with this cyclooxygenase. Okay. Any other question? Okay. Phenacetine. Phenacetine is a nitrogenous substance. Okay. Phenacetine is a nitrogenous substance. Okay. It's basically found in your, it's basically an antipyretic. Are we clear about this? It's not used anymore. It's an antipyretic. Okay. It's a nitrogenous substance that is found in an antipyretic, which is not used anymore. Okay. Are we clear right now? Yes, that's why it's a low potent NSAID. It's a low potent NSAID. Okay. Okay, perfect. Thank you so much for asking your questions. Do we have any other question? You are welcome, no problem. Do we have any other question? Okay. Okay, great. Okay, so let's start with the UWorld questions and the UWorld notes. Okay. Um, Before we do that, can you guys give me 1 second, please? You guys want to take a small break before we begin? Okay. Okay, I have another thing that I want to propose. instead of starting the UWorld questions and the UWorld notes today, we are very close to finishing the UWorld notes and the UWorld questions. Instead of doing them today, can we do an extra 10 questions tomorrow? So that today we can leave a little bit early and tomorrow's Friday, so we can stay a little bit longer. Okay, because that way it will allow me to go and visit my father in the hospital. And if that's okay with you guys, then I would like to end the lecture here today, and tomorrow we can do 10 more questions. Okay. Okay, perfect. So if that's the case, then thank you so much for doing the lectures. If we have any questions from you guys, please ask us those questions in via our email. And tomorrow, can we start the class a little bit early? Let's say at 8:30. Is that okay? 8:30. Let's start the class at 8:30. Okay. Let's start the class at 8:30 so that we can do 10 questions of UWorld tomorrow. Okay, instead of 5 questions. Okay. Are you guys? Thank you so much. My father is doing good. His procedure was yesterday. As a matter of fact, it was a good procedure. So we have to go and visit him tomorrow. We have to go and visit him today. As a matter of fact, he was having his procedure while we were doing our classes. So our class was a very good distraction for me to stay home and stay focused with you guys. So thank you to you all to help me stay distracted during our classes. So that really helped me out. So that's that. Okay, well, having said that, thank you so much. Please keep my father in your prayers. And another thing is, let's start the class tomorrow at 8:30 in the morning. And that way, what we can do is we can do 10 questions instead of 5 questions. And we can be ahead on our schedule. And tomorrow, obviously, we will finish the renal system. And what is the next chapter after the renal system? Reproductive and respiratory. Very good. So we will try to start a little bit of respiratory. Okay, respiratory, we'll start a little bit of that one. Okay. So having said that, thank you so much for all your love and blessings towards me and my family. The same goes for me to you all. And if you guys have any questions, please send us an email. And please send us an email. We will try to answer it for you. And even if I can't get back to you, we have a team who works with us. They will get back to you. Okay, most of the time I cannot get back to you guys, but our team will get back to you as soon as possible with any questions you guys have, anything about transactions, anything about videos. We have a whole team of people who work, and they will help you guys out. Okay, so having said that, hope you guys have a great day, and see you guys tomorrow at 8:30. Okay, see you guys tomorrow at 8:30. Bye.